both the first and the second kind of phases. But the very interesting silver line is that the recovery of COVID cases is high and the death rate is low. Of course, I'd like to compliment the Chief Minister, the Honorable Minister for Health, and the entire team for this great effort. The Honorable Minister has already been acclaimed by international organizations for the highly remarkable effort in combating COVID crisis in Kerala. But to this very special three-day meet and the inaugural session, it is my pleasure now to invite Dr. M.I. Sadullah, the co-chair of the FICCI Kerala State Council and chairman and managing director of KIMS Health. Over to you for your welcome address, Dr. Sadullah.
Good afternoon to everyone, and again, a warm welcome to each participant. Thank you, Sri Dilip Shanai, for the good words. I have an announcement to make. Our Honorable Minister, Shailaja Teacher, was supposed to join, and she may be joining, but because of the election declaration in Kerala and some of the directives from Election Commissioner, she's trying to get some clarity on that matter, and she has, it may be doubtful sometime whether she can join or not. Anyway, we will go with the proceedings because there are a couple of sessions following this. Our guest of honor, Dr. Dinesh Arora, Secretary to Government of India, Public Works and Power Department. Shri Dilip Shanai, Secretary General FICCI. Dr. Alok Roy, Chair, FICCI Health Services Committee and Chairman, Medicare Group of Companies. Shri Deepak Ashwani, Co-Chair of FICCI Kerala Chapter. Eminent speakers who would be joining for the various important sessions. Distinguished invitees from various hospitals, suppliers of various hospital service providers, FICCI team officials, ladies and gentlemen. I think this is a conference which is dealing with how we can transform the healthcare after this COVID pandemic, which has affected every sector of industry. And it's the biggest disaster for the mankind and has disrupted the human life worldwide. In the private sector healthcare, it has been a challenge because of the drop of patient footfalls. Elective surgeries came to a grinding halt, and international patients totally stopped. So all these impacts together brought most of the hospitals impact to 30% of the performance in Kerala and perhaps across the country. Those hospitals who started admitting COVID cases perhaps had some improvement. But in addition to these, we had to invest on materials, PPEs, and also the manpower impacts because of the COVID, which affect them also, and more the governance challenges. So all these have caused a severe liquidity crisis in addition to healthcare, in addition to all the other difficulties. Fortunately, since the last 2 months, or last month, I should say, there is some improvement due to the various facts in Kerala, for example. the COVID had a surge, and initially it was going very well, and then they had a surge, and now probably it is plateauing. So this is a good occasion. We can think about transforming the healthcare to find a new normal. We can ask questions how we can revive from this economic impact, how we can increase the margins in the private healthcare sector, even though probably the revenue may not go up. What collaborations are possible, not only between the government and the private sector, but the private sector and the private sector players. And how we can promote Make in India devices and products, and how we can rationalize manpower cost and the other consumable costs. The recent initiatives from the government of India had been very helpful, and like the moratorium on bank loan installments and without any penalty. Incentives declared for MSMEs, but I think it is still, I don't think health sector, anyone has received it, at least in Kerala. And state subsidies in the electricity bill and etc. These have, these stimulus initiatives have caused some amount of, improvements. We should also look at the medical value travel, how we can bring it, how we can make, Kerala a safe destination. Certainly, there is a lot of competition in Asian countries themselves, and a lot of other countries in Far East and all is really trying hard for that. And so we have to have a much more structured effort on this. Ayurveda and wellness tourism should be projected for the promotion of medical value travel. And I'm sure, Dr. Alok Roy will elaborate on some of efforts by FICCI in these areas. Kerala is actually well set for it because we have got the best, healthcare indices even now in India. And the quality of private and government sector even, the healthcare is really on a high standard, and high literacy rate, and there is a very good employability or employment generation opportunities from medical value travel. Insurance is a major sector we have to look into, and usually the general population is very small percentage insured, and perhaps this is an area where we all have to concentrate how the insurance can go up. And also we should try to loop the international insurance companies so medical value travel also can be helped out to some extent. I take a note that the government of Kerala has invested heavily and taken many initiatives to strengthen the state healthcare services. Even though the private sector still provides about 60 to 70% of the healthcare in Kerala, as well as most of the other states in India. So the public-private participation will be, this is a time we are really trying for the universal healthcare, and we are looking at, how we can improve the healthcare sector. So public-private participation and also private-private participation. Many hospitals, large hospitals should try to collaborate with the medium-sized and small hospitals, and it will be a great advantage for both parties if these collaborations can happen. FICCI has done several submissions to the government, several suggestions, and want to thank Sangeeta Reddy, Dr. Sangeeta Reddy, Dr. Alok Roy, and Mr. Dilip Shenoy. All of them had done a great effort in in uh, in in actually promoting this sector. With that introduction, let me just get to my job of welcoming each one of you. I think, Shailaja teacher, I don't know whether there's any word from her. Uh, Savio. So anyway, I welcome her. She had been very instrumental in dealing with the coronavirus pandemic very, very efficiently to start with. Then there was a natural surge which has happened. And now again, we hope to see that it completely plateaued out. I would also like to welcome my great friend and Dr. Dinesh Arora, at the moment Secretary to Government of India, Public Works and Power Departments. But he was very much in healthcare before. He was the CEO of National Health Authority, former Director, Health Voluntary Action, Niti Aayog. While he was in Kerala, he was also the Director of National Health Authority, NH, and yeah. And Dr. Dinesh, we are very happy that you accepted our invitation, and you will be the guest of honor. And thank you for joining us. And I take this opportunity to welcome on my own behalf and on behalf of the FICCI group. I also extend a warm welcome to my colleagues, Sri Dilip Shenoy, Secretary General FICCI, Dr. Alok Roy, FICCI Health Services Committee Chairman, Sri Deepak Ashwani, Co-Chair of FICCI Kerala State Chapter, and also a warm welcome to eminent speakers, distinguished invitees, and suppliers, media, and also the FICCI officials who have been very, very helpful and working hard to get this seminar going. Thank you very much. And we would like to hear from the speakers. And I would like to invite I'd like to invite Dr. Alok Roy for his opening remarks. And immediately after the this session, we will also proceed with the rest of the sessions. And this is for the information of all the audience. Thank you very much. And over to you, Dr. Alok Roy.
Thank you. Thank you, Dr. Shahadullah. It was such a pleasure to be here with you electronically. And my great regards to Honorable Minister for Health and Social Justice, Shailja ji, Mr. Dr. Dinesh Arora, and Mr. Dilip Shenoy, and all of you who are present here in this conference. First of all, I'd like to compliment Dr. Shahadullah for thinking of doing something like this from Kerala. And you have been truly a leader. Kerala has been leading the fight against the pandemic from the day one. As we all know that it resurfaced first time in India in Kerala. And that's where your fight started with the COVID. And you have done a remarkable job. Your government has done a remarkable job. Your people have done a remarkable job. Everybody has participated in fighting this menace. As we all say that, and we know it, that probably this is the biggest disrupting force in our lives. We haven't seen anything bigger than this. And the very fact that healthcare is the only wall standing between this pandemic and the rest of the society. Without healthcare people in the middle, there are a lot of people who are there, the frontline worker for right reasons. Whether it's a police, it's a government, whether it's a municipal corporation. But the foremost frontier is occupied by the doctors directly in preventing, in treating, and sending patients home on their own legs. Now, today, the entire world has become COVID tainted. We don't get just a pure cases of COVID anymore. We are getting a patients who come with the MI as a first symptom of COVID. They come with the ICH, intracranial hemorrhage, as a first symptom. They come with a lot of other features which are far, far from COVID. That very clearly shows that COVID is getting into the every presentation and manifestation of disease in many ways than what we thought of. And our learning of COVID in any case is just 10 months old. So the very fact that Kerala State Council, headed by Healthcare Chair Dr. Shadullah, decided to go about it and deal with it in a manner befitting to handle the COVID menace in our country. The very fact I've been seeing your plan and where you are, what are the survival plans? Rightfully so. Healthcare has gone through a very, very bad patch. We are not very rich people in healthcare, and having gone through this pandemic, people have lost a lot of things. Hospitals have shut down, people have lost lives, and the very fact you are thinking about how to survive, how to strategically align with the larger hospital, how to, what are the post-COVID opportunities, and which are already becoming visible to us, how the lungs have become very important part of our day-to-day living, and how to add the value travel, medical value travel, tourism. I think it's a great way forward for Kerala, for FICCI, and for Dr. Shadullah under his able guidance from Kerala. FICCI has been working on the forefront. We have been working very, very closely before the pandemic hit us until today on various fronts with the government in association with every forum which represents healthcare in India, whether it's Nat Health, SHM, AHPI, FANA, everybody we have FICCI has been working with. We want to let people know that private healthcare is with them, because this fight cannot be won, or this battle cannot be won just by the government. All of us have to contribute to this war, and FICCI is committed to that. So without wasting much of your time, I must compliment the team in Kerala. Kerala State Council just thought of it, and anything we can do for you. Our biggest battle is on our way, that is vaccination. I'm sure we'll all will join hands and defeat that too. Thank you. Have a great day.
Yeah, thank you very much, Dr. Alok Roy, for your kind words. And now it's an honor and pleasure to invite Dr. Dinesh Arora for his keynote address. And he is everything today. He is our chief guest. Thank you, Dinesh. Over to you, Dr. Dinesh.
Thank you so much, Dr. Shadullah, respected Mr. Dilip Chinoy, Alok Rai, and Mr. Deepak Aswani, and all others who are present here. Two observations before I make a small speech. One, when Mr. Alok was saying that, look, at this time we have gone for rebuilding health sector under the aegis of Mr. Shadullah, I remembered a quote from Rumi, who said that if everything around seems dark, look again, you may be the light. I think Dr. Shadullah and his team is the light today for rebuilding the health sector in association with FICCI, and I really compliment it for thinking aloud, thinking boldly, thinking how should we go forward. Second request is to Savio and all FICCI members, please do not have somebody like Dr. Shadullah welcoming the delegates. because he himself is a subject expert. He doesn't leave anything else for people to speak. He has really pinned it up saying that, look, you have a strength of Ayurveda, you have a strength of medical tourism, you have a strength of MSMEs being supported by Government of India, the installment moratorium, which all actually I was supposed to speak. Of course, I can take one credit here of the electricity bills, which I issued the government order in Kerala. So the bills decreased during the COVID time. Nevertheless, perhaps this is a crisis like none other. You know, in one of at Johns Hopkins, when I said once that this is the crisis of the century, somebody objected and said, look, we are in times where bigger crisis can come than this. So I've stopped using the crisis of the century, but crisis till date, we have never seen like this. And it has affected everyone. The economies have been destabilized, right? Looks like even worse than the economic depression and the recession we had 100 years back, the 1920s even. Every country has lost its GDP. It has disrupted both supply, market, and the demand. All have been affected in this. Health systems have taken a beating. As Dr. Shahidullah said, elective surgeries have gone down drastically. Normal immunization has gone down drastically. And societies at large have become living differently. So what is a new normal? We are yet to evolve, and we are evolving towards this, but masks definitely a new normal in this. But I think there are 3 silver linings in this whole corona crisis. One, if anybody had doubt between the relationship of economy and health, tested till date, this virus has shown that economies will suffer if health is not protected. So I call this as economic virus. The corona is an economic virus. It has shown to the world that the linkage between health and economy is so strong that we at the bureaucracy, we at the politics, we should understand and start investing in health. Second, the countries which had a better universal health coverage, may it be New Zealand, may it be South Korea, may it be Japan, Singapore lately, have done much better in handling this pandemic. Another lesson for a country like India. And thirdly, for the first time, public health has been in a spotlight. Public health has been a spotlight. Preventive health is in a spotlight. So I believe these 3 things we should move forward and translate into definitive gains for private sector, health sector in such. You know, people always single out public sector, private sector, regulation, and people identify saying that, okay, private sector is for profit, private sector may have better efficiency, may have better quality. And then this again go back to the public system saying they have to provide equity. They have to provide access to all. I strongly differ in this. For me, it's health sector per se. Both are important. Both need the same recognition, same prerequisites as it is done for the public or the private. In fact, both complement each other. If you talk about any field which is going to happen, whether it's, say today we're talking about vaccination, Mr. Alok finished saying vaccination. Who is doing the trial studies right now? It's the Bharat Biotech, the Serum Institute, and many other companies, which are all private. Are we not banking on them? And then government needs to take over and provide this as a merit good, as a public good. So the problem comes when we start mixing a public good that private sector should provide a public good. I still believe when, a judgment came that all tests for COVID should be free of cost in the country. Agreed for the public sector, but how will private sector bear that cost? First thing came in my mind. And so the learned judges also went into this fallacy of merit good without understanding the markets, without understanding the dynamics of how to do it, who will do it. I'm glad Government of India did come up with a stimulus package. Health per se was not very evident, but some things were very well discussed. One was they talked about increased spending on health, improving infrastructure, especially primary health wellness, and doing some structural reforms. We are yet to see the detailed print of this, but I'm sure with Corona there, a lot of learnings are there, and people at the helm of affairs will take this into account. I can share a couple of my experiences when we were working I was working at Government of India. One was when we were working at Niti Aayog, we remodeled the draconian MCI thing. Now it's National Medical Commission. And I'm sure many of us, and I encourage Dr. Shahidullah himself to go and open up a medical college. Dr. Shahidullah, now things are changed. There's no inspector rats there. Now it's more of a requirements, no standard setting, no inspections. We have decreased the quantity of land required. Even different parcels can be used. Only thing required is a functional hospital. 400-bedded hospital for 100 seats. 800 hospital for 200 seats. Let's begin with 100 seats at KIMS. I'm sure this will be a great proposition. All norms have been decreased, like library or having so many manuals, generals, and we have tried to make as easy as possible. You can share faculty. There can be a visiting faculty. So one reform which I was a part of it was the National Medical Commission, which has been notified after a great battle led by the Honorable Prime Minister himself in the Parliament, and where we could go through. The second was of Ayushman Bharat, where when you talk about insurance, this is an insurance scheme right now for the bottom 40%. And why we went for bottom 40%? I remember when we were making presentation to the Honorable Prime Minister, the morbidity in the bottom 40% is higher than the rich 40%. But hospitalization rate of bottom 40% is 2.6% as compared to 5.2% for the rich. That means they are denied the facilities which they require. Whether it's public or private, they are denied. And this was the theme where we went for a demand side financing. For us, public or private hospital were one. So a national health authority was carved out outside the health ministry, just to have an arm's relationship with the public as well as the private health. And that's perhaps the way forward. I'm sure many of you were not very happy with the rates which were set up there. And it's a continuous phenomena which is getting evolved. And I look forward to participation of most of the hospitals in this. Today, in fact, about 15,000 hospitals are private hospitals who have got themselves empaneled. And 1% increased hospitalization will lead to 65 lakh more hospitalizations, 65 lakh hospitalizations more. And this will transform into demand for doctors, nurses, paramedics, for diagnostics, for medical equipments, pharmaceuticals, and whatnot. So I urge everyone to look into that. And this is going to happen with CGHS being merged with Ayushman Bharat. And lately, we're also thinking of increasing it to another 20%. So 60% of the country would be covered very soon under Ayushman Bharat. This is what the plan I was hearing when I was there. So I will urge all the private sector hospitals also to think about it, join Ayushman Bharat, help in team building. And I also assure you that the government of India is also working on how the prices could be matched, which should not be a loss for any private sector hospitals. The stimulus package actually, which was announced, had a lot of inbuilt things, like when they talked about quantum jumps in economy, when they talked about infrastructure being removed, when they talked about technology-driven system. I think technology-driven system is the one on which the hospital sector can piggyback, whether it's the trinity of mobiles, internet, as well as Aadhaar card. And now with recently National Digital Health Mission being launched, which will come up with a unique ID for every individual in the country or the family level. This will help us in increasing the access to services, not only in the public, but also in the private sector. Similarly, the call for local, vocal for local is actually the essence right now. With tempers high against China, I think India stands at a very peculiar position here. And Indian pharmaceuticals and equipment industry has risen. At the clarion call of the Prime Minister, from nowhere we could generate 200,000 PPE kits every day. Masks, equipment, sanitizer, no shortage here. When I was in US, not 6 months back, we had difficulty in getting masks. One mask was available for $10. Sanitizers were not available. Costco had already written everywhere that no sanitizer is available for next 1 month. Amazon was supplying at 6 months gap. But here India rose out and even had ventilators ready. In fact, to talk about hospital beds, private sector has 70% of the beds. In fact, 85% of the ICU beds. Where is government of India going to look to? Has to look to towards private sector. One silver lining in this corona thing has been that government needs to consider and is considering private public as partners at an arm's length, giving the same status, same facilities, and same expectations from both. I think Kerala is in a peculiar position where the regulatory environment is also pretty open, and we hope that with this corona vaccine coming, things will improve. This is not going to be a drastic improvement because supplying to 1.3 billion people itself will be a challenge. We have so far results from Pfizer and Moderna, which has about mRNA vaccines, but not available for India much, already pre-booked for the whole US and Europe countries. But we are looking at our own indigenous supplies of Serum Institute of Covishield or Covaxin from Bharat Biotech. And supplying this will be a challenge. And here, again, it has to be a shoulder-to-shoulder responsibility of public and private here. I'm sure Government of India is collecting data right now of healthcare workers, which they are doing from everyone, not only from the public, but from private and including indigenous systems of medicine. So I wish and hope that we go forward together and rebuild the health sector in a much, much better way. We have the advantage of medical tourism. I still remember in 2000, when one of my relatives had gone to US, the cost of cardiac surgery was $50,000, and in India it was about $4,000. In 2018, the cost in US has doubled, $100,000. In India, it has halved, $2,000 to $2,500. And the clinical parameters have improved from 94% to 99%. The outcome has improved. I think we are at a very important stage here. We need to understand the market dynamics. We need to understand that government has to chip in to supply for a larger sector and allow built on the efficiencies on the private sector. So whenever I speak about 6 P's required for universal health coverage, and which includes a political commitment, which includes a predictable financing. India needs to spend much more than what it's doing on health. Priority setting, very important. Like Mr. Shadullah said, for him, it could be a medical tourism. For him, it could be also in particular sectors like Ayurveda or wellness. Patient-centric, primary first. I think that's where we need to work also with the hospital sector here. In Maryland, they have come up with a model called all payers model. So for example, if KIMS is in one area, they can give that area as a catchment area and say, look, you are responsible for health of these 25 to 30,000 people around, along with whatever people come from outside these areas. So Dr. Shahidullah then will not construct a new hospital, but he will say, I'll open a primary health center because I am being given a lump sum money to take care of all these people. And I will love them to be preventive rather than fall sick and then treat them. Of course, people will fall sick, people will need surgeries, people will need accidents will happen, but prevention will become a key there. And these kinds of reforms, what we are looking for India in the next phase. And I'm sure private sector leverage has to be there because they come with innovations, they come with testing innovations, and they can also come up with scaling up innovations. And that's where the private sector scores much higher and should score higher. And India should facilitate. Thank you so much for inviting me. Thank you so much for giving me time.
Thank you, Dinesh. Thank you very much indeed. And, I think some of the COVID time you spent in the US and Johns Hopkins and probably, so you had experience both in India and US about the COVID. Thank you very much for your, good speech and very interesting points, how to revive the health sector. Can I invite, Deepak Ashwani for word of thanks for our guests here, and before we go to the next session. Thank you, Deepak. Over to you.
Thank you, Dr. Shahidullah, and thank you very much, Dr. Dinesh Arora, for that wonderful speech. In fact, we were eagerly waiting for the Minister for Health, our Honorable Minister for Health, to come in and actually tell us all about how she had made her mark across the country on how COVID was controlled after the deadly Nipah virus also had taken its toll in Kerala. Unfortunately, these municipal elections have stopped her. But what you have spoken, you virtually stolen all the words that one had to say about the pandemic and the health crisis that the country faces. In fact, a big salute at the beginning for all the health workers, the doctors, all the frontline people who have been a wall against this major crisis, as you very rightly said, the ecovirus, and which has almost caused a disaster both in the economy as well as in the health front. Many countries themselves are tottering on their knees right now, and hopefully we've learned a huge lesson from this pandemic. And where we are right now is basically somewhere in the middle, I guess. And I really pray so, that we can come out of it very strongly and will never allow anything like this to happen again. Your understanding of the situation is amazing, sir, and we look forward to you as the Union Health Minister sooner or later. Thank you, Dr. Roy, for representing Vicky, and again, telling Vicky Kerala what a wonderful job Dr. Sadullah has been doing on the health front. Actually, in many of the meetings that we've had with the government and stakeholders, it has actually come to us that medical tourism and tourism put together is going to be the next biggest thing in Kerala. And if we can make this, and also going by the mark that our government has made in the actual control of the disease itself, shows that Kerala is going to be the next big destination both for healthcare as well as tourism. We will recover faster than any other state or country, I guess. And we have a number of wonderful speakers today who are going to talk about various facets of this issue. This particular webinar has come at the right time, and so the right time to transform healthcare in Kerala, keeping all stakeholders in mind. I thank each one of you. I cannot, it's a huge list, so I'm not going into it personally, but would thank everyone and hope this webinar fulfills all the objectives that it has. Thank you once again for attending, and looking forward to a very enriching session ahead.
Deepak, before you close, with great apologies, I think I forgot to invite Dilip Shanai, who is the Secretary General of FICCI, and he was supposed to speak. Dilip, can you say a few words? You are well informed, and you were supposed to speak. I'm sorry. I'm really sorry about it.
No, sir. Actually, I spoke. I welcomed everybody. You took it over. So thank you. It's all done. And
Dilip sir is our moderator, and he is one of us. So the welcome and thanks both to him too, sir. Thank you, sir. Dilip sir.
Dr. Sharathullah, I think we have concluded the first part of the inaugural session. We can move to the second part. Sri Vibhu Punaran, our co-chair, FICCI Kerala State Council Health Secretary, is the moderator of the session, and we have all the other speakers also joined for the session. Dr. Alak Roy is still here with us, and Sri G. Vijayaraghavan, former member Kerala State Planning Board, also joined. Sri Harish Manian, CEO MGM Hospital, also Chennai, also joined, and Sri Uday Dev, Financial Advice Schemes, has also joined. So over to Sri Vibhu Punaran to take over the proceedings.
Well, good evening, everyone.
I would like to introduce Vibhu before taking over. Vibhu is known to everybody. He is, as already mentioned, he is the co-chair for the FICCI Kerala Health Sector, and also is the MD for the Medivision Scan Diagnostics Research Center in Private Limited, and he is also the Honorary Treasurer for the Kerala Management Association. Over to Vibhu.
Thank you, Savio. FICCI Kerala Chair, Health Committee Chair, Dr. Sadullah, Mr. Deepak Aswani, speakers for the day, Dr. Vijayaraghavan, Dr. Alok Roy, Dr. Harish Manian, and Mr. Uday Dave. Welcome to this meeting. Before we start off, as you all know, our topic for discussion this evening is increasing the margins even if the revenues are not going high, and rationalization of cost and manpower for the private sector, sorry about that, or rather the survival plans for the hospital industry to meet the economic impact that we are have faced so far. With a small introduction, let me just welcome all our speakers. I don't think any of the speakers need introduction, but I'll just put in certain figures before we go on to this. See, there is a perception that the private hospitals are charging too much higher bills, as in a state like Kerala, where we are very price conscious, and also where we are generally health conscious. There is a feeling that the private hospitals do charge much higher than what they should be charging, and despite all that, the private hospitals say that they have made losses. Definitely, yes. Dr. Sadala is very much here, and I'm sure that we've had private talks, and it has not been very good for all of us in the healthcare industry so far. And the first quarter of this fiscal saw practically nothing. Then the second quarter, of course, we have shown signs of revival, and let's hope that the rest of the year is going to be better. There are so many factors that have contributed to all this. Basically, it is that some of the state government has put capping on rates for many investigations right now during the COVID pandemic. That probably had played havoc in the initial stages, but then later on the reagent costs have come down, and people could support themselves. That is one thing. Then many of this, the healthcare sector, as we know, is not comprising of just the major hospitals alone. It is also confined to most of the private clinics, smaller time hospitals, diagnostic centers, and all that. Putting all that put together, many of them had to shut down completely because of lack of footfalls. And then a major problem that is bugging all the private sector hospitals right now also is that there's a perception that the biggest breeding ground for COVID-19 is the hospitals. Although we have started seeing a lot of people in probably the shopping malls and things like that, we do not see many people in the hospitals because of this fear of the pandemic. And not only elective surgeries, even people have put off going to the hospitals for various reasons. At the same time, the hospital costs have gone up because of a lot of staff turnover, sanitization, additional precautions to be taken before making people enter the hospitals, and all that. So employment of many staff on ad hoc basis had to be done. And the steady inflow of chronic illness, patients with chronic illness has seen a sharp downfall. All this put together have contributed to losses to the private sector hospitals. Whereas the public sector hospitals, of course, they can survive because of government funding. With this introduction, and I do not want to keep the learned speakers away, I will just, for the benefit of all the others participants, I will just give a brief introduction of all of our speakers. Dr. G. Vijayaraghavan needs no formal introduction, but as custom demands it, I'll just rush through. He's a former member of the Kerala State Planning Board, and he's the first CEO and the founder of the Technopark in Trivandrum. He's an expert in technology who paved a way for a varied path in the technological development of Kerala, honorary director of the National Institute of Speech and Hearing, Trivandrum, and he's the man behind the Asian School of Business. Dr. Alok Roy, again, he was a speaker, so he's the chairman and managing director of the Medica Synergy and group of companies, and chairperson Medica Home Care Services, and he is an expert on the global healthcare scene. And Mr. Harish Manian is a healthcare management professional with almost 2 decades of experience in the P&L role, covering project management, operations, business transition, and business development. He is the chief executive officer of MGM Healthcare. He has worked across various healthcare ecosystems, hospitals, pharma consulting, medical technology consulting, and ITS across various geographies. And Mr. Uday Dave, he's a group financial officer of the KIMS Healthcare Management Group. He's a chartered accountant by profession, and formerly he was with the Sterling Holiday Resorts. I welcome all of you, sirs, to this evening moderate meeting, and I would request Dr. Vijay Raghavan to take over and give your insights into what we have to say. Sir, can you please unmute yourself?
It was muted. Yeah, okay, good. Thank you very much for inviting me to this talk. First of all, I'm not a doctor, so it's just Vijay Raghavan. There's no doctor there.
I'm sorry.
There is another very eminent person as Dr. Vijay Raghavan, who is the vice chairman at the KIMS Hospital. And now for those of you in Kerala know that you have the party secretary also, another Vijay Raghavan. In fact, I get, whenever they get something, I get a congratulatory message. In fact, 2 days ago, I had one of the Kerala ministers calling me up and congratulating me, and I asked him for what. And then he realized that he was talking to the wrong Vijay Raghavan. Okay, he was congratulating for me for becoming the party secretary. Anyway, good. So, I mean, coming to the hospital, one thing is very clear, that your costs, your overall cost, if you look at what you're spending, may not go up, but your cost of delivering of services is going up. So you will find that if you really look at your cost per patient who is coming in, that number has gone up substantially. All right. Now, because there are some costs which you just can't cut, but in times like this, there are costs which increase because of the additional, I would say, the additional precautions or the additional measures that you need to take. Your costs are increasing. And there will always be, as after all, it is one bottle of sanitizer, or it's a PPE kit. But when you add the total number of what you need on that, you will find that whole thing together is a big cost. So from the point of view of hospitals or people in the medical field, it is necessary for you to look at every rupee that is to be spent, because 1 rupee spent in 100 places is 100 rupees. So don't look at it as 1 rupee. So every rupee that you spend needs to be very, very carefully looked at as you go forward. The second one is, I've actually, in some conversations recently, I've looked at certain numbers for hospitals outside of Kerala. All right. And you find that those numbers are much higher, what they charge. So, even though when you say that people complain that the rates in Kerala are higher, I would say the industry as a whole, and maybe FICCI and organizations like that, probably have failed in terms of making the common man understand that the costs are much, much higher in other parts of the state. We are not talking of another country. We are talking of a place like Bangalore or a place like Chennai, or even a place like Coimbatore or somewhere like that. If you look at it, you will find that your RPOB levels are much lower here. Your revenue per patient is much lower. Your revenue per OP is much lower. So very clearly, that is something which I think the hospital associations need to work on, to let the people know that, you are saying that our costs are higher, but actually we are substantially cheaper than the rest of the country. And when it is the rest of the country, you should remember that the costs are very similar. In fact, in Kerala, the costs are higher because you have the minimum wages that have been put in for the nursing teams, which are much higher than other states. So if in Karnataka or Tamil Nadu, somebody is able to give a service at a particular cost, they charge something, you should remember that your cost of providing that service to somebody in Kerala is going to be much more, because your salary levels, especially the nursing staff and others, which is a big component in your salaries, is much higher than what is charged in other places. So that is something which you need to be working a way by which you can look at how this can be conveyed to the public and how do they come to understand about that. The other one is, like I talked about, every rupee counts. You need to look at where is the wastage happening. In the theaters, is there something used more than it should be used? In the labs, is there something being used more than it is used? Can you actually look at a model by which a few of you get together and then negotiate so that you get better rates? All right. One of the things which you find in Kerala is that, yes, you all are part of an organization, association, but I don't think you are leveraging your collective strength for buying. Okay. So can you look at a model by which you don't have to look at everything, but at least there are certain things where you can actually, that strength of your numbers together is much more than each of you trying to negotiate with somebody on that. How can you do a model like that? So these are things which you will need to think in times like this, because the cooperation between hospitals. One of the things I know, for example, I don't think many of you all share data, but you look at countries around the world, you will get a lot of hospital data very, very nicely because all the hospitals declare that. So is it easy to create a common standard on that? Could be difficult. But at least if some of the top hospitals decide that we want to do it together, you will have a lot of that coming together. You will be able, your strength of negotiation, the negotiation will be from a position of strength, because maybe there's a 600-bed hospital or 1,000-bed hospital. There's another 1,000-bed hospital, means you've got 2,000 beds for which you can be negotiating for certain things, not everything. That is another thing which is there. The third thing is, how do you make the productivity levels of your staff better? How do you increase the productivity level? How do you ensure that, I'm not telling that you should cut on the costs that are there. I mean, cut on people for the sake of cutting. But can you find out whether you can look at your cost per bed coming down, cost per OP patient coming down? If that is the case, unless you start looking at those, you're going to find it very, very difficult to actually make ends meet. I'm not talking about profitability, ends meet. Because if you are working on profits of 15-20% earlier, and your revenue has come down by 20%, you're already at a substantial loss. So very clearly, that is something which, and I think your revenues would have, like you said, the first 3 months was a washout. I don't think many hospitals would have reached even their regular levels earlier. So practically, for all purposes, your first 6 months is a washout. In the first 6 months, you would have made revenues equivalent to about 1 or 2 months in the year, which means there's 4 months where you're getting no revenue. The rest of your 6 months after that, the second half of the year, you will still not be able to match what you were doing in an earlier year, while your costs have gone up. All right. So unless you've looked at cost in a very careful manner, and that cost includes, like I said, the 1 rupee item or the salary of individuals, you need to look at very carefully. That is probably the only way you will be able to make ends meet as you go forward. The other one is, look, every challenge that comes up is an opportunity also. It is for each of you to look at, to find out what are the opportunities that I can find in this crisis. How do I change the model that I have in my business to try to come out with an innovative model where I'm going to give the patient an exponential benefit, and I probably make some money on that? How can I do that? What are the models that you can do on that? Home care. Home care, I know some of you already have, but can I look at home care becoming something very important? So if the doctor is charged 250 rupees or 300 rupees for a GP in the hospital for a consultation, the home consultation, they would have no problem giving you 500 or 700, because they will need to take a transport to come to the hospital. So you need to look at how can you look at those and come out with models where you're using this challenge as an opportunity for taking your business forward. The next one is, how do I use technology in this? How do I use technology in terms of how do I ensure that the teleconsulting, how do I look at that? How do I look at using technology in terms of services to patients? How do I look at using technology to make things in the office much better? In the hospital much better. How do I increase patient service by using technology? How do I look at the interaction with patients being much better using technology? These are all things where there could be a capital investment, but you would actually bring down your costs substantially. Can you look at contactless service to a great extent? At the end of it, the doctor will need a contact, but how do I do that? So I would say it is necessary to think differently at these times and look at what are the opportunities that these challenges pick up for for each one of us. That is something which you definitely need to look at. So very clearly, the opportunities that come out of these challenges are what each of you should be looking at to actually seize in such a manner that the business can get converted to be positive in a very difficult year that is there. I would also say it is a good time to invest in your key people. Use this opportunity to invest in your key people so that they become better deliverers of healthcare than what they were before. So these are, I think, opportunities which you should look at. And I know I've taken the time that was allotted to me, but I'm open for any questions once we complete the panel discussion. So thank you very much, Mr. Bibu, for, and thank you, Dr. Saudullah, for inviting me to speak at this session.
Thank you, Mr. Vijayaraghavan, for having enlightened us on this. And the takes that we have from you is that, while our costs are increasing, our revenue is not increasing, and FICCI can do much better to bring down the costs through collective strength of negotiations, and also making the people in the state aware that due to the pandemic and other factors, our revenues have been hit, and so people should not make a hue and cry on what is happening. And also, you have also enlightened us on making use of newer opportunities like home care and telemedicine and all that. Thank you very much, and definitely we are taking in your inputs. I would now request Mr. Harish Manian to kindly express your views on the subject.
Very good afternoon, and very good afternoon to Dr. Saudullah sir. Actually, thank you for inviting me into this session. It's been always a privilege to meet him, either live or offline or online. I think it's always a privilege to meet him. And also the other panelists, Dr. Alok Roy and Mr. Vijayaraghavan, Uday, everybody, thanks. The good part about this opening session by Mr. Vijayaraghavan was that he has covered almost every point which we have made out, actually. So there is, a largely, very comprehensive discussion which he has put forth. So I think, I'll take a cue from there, and just my viewpoint on the entire scenario at this stage is, every other industry has taken this opportunity of COVID pandemic and transformed the business. I think healthcare also needs to do the same. That's what my belief is, that because we are the ones who are in the middle of the action. I think many of the industries are always in the periphery of this whole situation, but we are right there in the center of the action where things are taking place. So a lot of things have changed in healthcare over the last 8 to 9 months, ever since we have seen life happening from 24th of March onwards, actually. So some of the statistics which I have seen is that, some of the platforms which were really done well is during this particular course of time is the OTT platforms are done extremely well. The subscription rates have gone up 2 times, 3 times. Automobile industry has bounced back. They're clocking all the pre-COVID numbers. Their numbers are even exceeded in some cases. New launches happening. I think most of the industries are trying to see, except for tourism, which is taking a slow pace of recovery because of the restrictions still existing in many other areas. But leaving that, I think most of the industries are trying to crawl back into their own action. And that calls for how healthcare has to do something different, actually, apart from what it is being doing so far. My take on the entire scenario is that this was its own mechanism by which it can actually, we should be able to reboot the industry, because it was kind of a situation where things were not looking, as far as the industry was looking, very complacent, to be more precise, according to me, because this was nature's its own way to actually shake up the industry and say that, guys, hey guys, you need to actually relook at these models, because there were so many underlying things which we have done in the past which are not being used to effectiveness in healthcare, which has started becoming more prominent. A very typical example is that I've been a major proponent of telemedicine from 2001 onwards. Ever since I started my career with Manipal during that time, I used to go door to door across the country asking for starting the telemedicine project, actually. And far and few were interested at that point in time. And we also signed up with ISRO at that stage. But taking that today, I think a technology which was almost 20 years in existence has to take 20 years to come to a platform where people are talking about in numbers and publishing data. And if anybody would have gone and seen the website of Cleveland Clinic, in fact, that is exactly is known as farsightedness in terms of how to look at a product. They have actually published in the website in terms of 120 odd diseases or 140 odd diseases for which you need not come to a hospital. I think none of the Indian hospitals have done it so far. The reason why we are always worried is that we are always looking at the low-hanging stuff in the Indian industry. What has happened is Cleveland has actually gone and announced that for these 120, 150 odd diseases, please don't visit hospitals. What has done is their reputation as an organization is far-fetched. They've used online platform to treat all these 120 diseases by keeping people away from the hospital. And normally what, according to me, has happened, somebody who gives you an option of not coming to you, you will try and inquisitively go towards that particular thing. That's a normal human nature. And that's what I felt very innovative about Cleveland Clinic doing that much ahead of all of us 2 years back. So they had a platform which was already with the public, which they were using. And now in our case, I think what has happened, we need a pandemic to, actually understand the power of technology in our industry. Many hospitals have attempted a lot of things in technology, but I think pandemic has brought technology into forefront. The technology which was 5 years ahead of us, we have started adopting it today itself. I think that's the biggest boon for healthcare as far as technology is concerned. Mr. Vijayaraghavan actually emphasized on technology. My take is that technology can completely transform now, and this is an opportunity in front of all of us to invest in technology and ensure that we actually maintain our customer base more effectively, India as well as internationally. I think this is a great opportunity for all of us. We should invest in this. That's something which we have to look forward to. Coming to cost and increasing margin pressures across the hospital, I think that's been a debate going on in Indian healthcare from I think we've been boiling ocean on this particular topic for quite some time. And I will always go and subscribe to what Mr. Vijayaraghavan said. I think there was no single uniform voice in our industry. That's the, I think, sad part of it, because anytime there is a price regulation, every other person in the industry has gone and circumvented the mechanism by which they can charge extra and ensure that they can actually manage the cost in some way or the other in their own geographies. But there is nobody who has come and said that, okay, hey, we can't do this procedure at this particular price point. It has to remain there. This is the only industry where the product matures and the price comes down. This is something which is an irony of this industry, because when the product matures, I think the price should go up according to, as the metric stands. You get a new way of doing a CABG surgery, actually the cost comes down for us, because every year the CABG, which was 5 lakh rupees 5 years back, today it's at 1.5 lakhs actually. So imagine the price erosion and the margin erosion happening. But can you think that the Singapore has started doing CABG surgeries as 1/10 of the price which was 5 years back? No way. They have actually gone up. So what is happening in Indian context is that we ourselves are bringing the price down, putting margin pressure on the industry. And we are also worried about the fact that we have a growing pressure in terms of manpower. If you see the cost structure of a hospital today, there are only 3 components which actually swings the entire business. One is the doctor cost, another one is the material cost, third is the manpower cost. 70% of your entire P&L stands there. And if you can manage this cost more effectively in some form or the other, I think Mr. Vijayaraghavan mentioned about group purchasing. I think there is a lot of effectiveness coming through, a lot of, I would say, aggregators coming into play and trying to get you some another 5 or 6% margins at this stage. But having said that, I think that is just a delta of 5%. But I'm a great proponent of top line increase. There is a huge opportunity for us, because traditionally we've been underplaying our price points actually. So I think we have a great opportunity, because the purchasing power of an Indian consumer has gone up over a period of time. I think, but we are still continue to underplay healthcare, because what happens in healthcare is whenever we get an opportunity, we always think it is something which is a government subsidized. Nobody speaks about healthcare as a business, because we need to know there is people involved, there is manpower involved, there is huge cost involved in running the business. Because whenever somebody talks about healthcare from a business standpoint, it's always been a taboo. Because I was talking the other day in CIA also, nobody is keen on talking about healthcare as a business, because that becomes a taboo today in Indian context, because they think, okay, healthcare means nobody can talk about money. People have to talk about only charity, talk about outcomes, talk about clinical, stuff, and so on and so forth. But there is a larger interest in terms of the stakeholders involved in that, and the business has to grow. Otherwise, there is no win-win situation. The situation today in India is similar to that. I think there should be one voice where we actually come and say that, hey, this is where the industry works. Very valid point by Mr. Vijayaraghavan. Cost of running a hospital probably in Chennai, in Kerala, is much higher compared to probably Chennai and Bangalore, but the price points are much lower. I think this is a very, very valid point. I think nobody is questioning. Second, electricity charges in healthcare. I think you might be surprised to know that the charges which is levied to a healthcare hospital might be equivalent to an entertainment industry today. And there is no comparison. Margins are not comparable. They make 200% profits and we make 14% margin. So how we can levy a same kind of an electricity charges to a hospital versus an entertainment area? So there is a lot of dichotomy which people have to actually delve into it and try and come out with certain kind of innovative way of looking healthcare as a separate vertical. We can't be seen as a Me Too industry which is running as part of the whole rat race which is happening inside the industry itself, so to say. That's one. So I think that's where it is. There is a great opportunity as part of pandemic to go into new markets. That's what I feel. I think that's one point which I feel is very, very critical at this stage, because people who want to expand the industries, the hospitals which want to go to new places can definitely explore, because the margins have got now slightly, the multiples have got corrected at this stage, because earlier the quoted multiples from private equities was much higher. Now entering into a new marketplace becomes even more easier. Entry barriers are lowered. We can actually get into new markets with a better price point. That also is helping at this stage to expand. If you would have seen, pandemic has done maximum number of deals during this time, unlike any other time. But people thought everything will be slowing down, there will be no money, but private equity has invested the highest during this particular time frame, and they have actually picked up good assets and moved into different markets and geographies. I think so that was a great opportunity, and it will go on for next 6 to 1 month, 1 year for sure. That's what I believe. So these are some of the points which I have taken. As I said, there is an opportunity which is lying from a revenue point of view for every hospital, which they never thought it is there, I would say, line of sight or say primary focus in a hospital setting, because people never thought about home care business more seriously. I think there are some hospitals who are doing home care, but they were not serious about. People never thought about elderly care seriously, but people never talked about transition healthcare. Now people are talking about it. So the areas which were not so critical for hospital to make money will become critical at this stage, because transition care beds is a good opportunity which is never under regulation. I think it can actually fetch you certain kind of EBITDA margins in terms of if you're running the business. Similarly for elderly care, home care, I think all will get regularized under the umbrella of hospitals, because this will be another additional opportunity, because you are generating that business from in-house. Because this is not somebody, you are generating that business and giving it away to somebody else. Might as well keep it with you and make more margins actually. So that's an opportunity which everybody will try to leverage during this time. Similarly, I think clinical areas, there are a lot of new avenues which have opened up. It's not right to say at this stage, pandemic has its own effect, but clinically, I think some of the organizations have developed some new specialities. By default, what has happened because of the pandemic? There is lung-related diseases which have become more prominent. ECMO services has taken more prominence in India. I've seen more ECMO inaugurations happening in the last 9 months than ever before. Every hospital is interested in starting an ECMO services by itself, because that's come as a mainline therapy for treatment. And also for post-COVID lung damage, I think there are a lot of work happening. So clinical specialties are also changing, and many organizations which are able to adapt to these clinical specialties are also able to sustain good revenues at this stage. Because what happens in this particular scenario is your business will definitely transform. And if you don't adapt your business to the new business rules or the environment, there is high chances that you might actually go down the hill. So there is this kind of an opportunity which is available. I think if the clinical team is strong enough to drive that volumes, that again caters one more line of, I would say, revenue stream for a hospital. So these are some of the things which comes to my mind when I talk about this point, because I'm a great proponent of talking revenue up, cost down. I feel always there is opportunity for revenue in an organization or a market wherever you go. So there is enough to leverage at this stage. There is enough opportunity within an organization. I think these are the lines probably everybody should start thinking and taking the business forward. And of course, keeping a check on the 3 points which I mentioned from a P&L point of view. I think that will save us for the next of the year.
Well, thank you very much, Mr. Harish. Yes, you have given us lots of valid points on and your take on increasing revenues by getting into newer healthcare systems like telemedicine, and also it's a new learning that about 120 to 140 diseases can be treated even without going to the hospital. That should be something that most of the hospitals should adopt. and take things forward. In fact, my own son, who's just a medical intern, had consulted a doctor online for his problems, and that is when personally when I came to know that this could be leveraged so much. Like sitting in Cochin, you can consult a doctor in Bangalore or in the rest of the world. So that's a major thing. And of course, newer markets can be explored right now. And the Kerala scenario is slightly different from the rest of the country because our people are very much conscious about many things, especially we're price conscious. And what you said is very right when it comes to profits. It's considered taboo for the healthcare industry for reasons we do not know. But then that is how it is. It has been all along. But of course, major hospitals like the KIMS Group, as an example, they've invested so much into technology, so much into infrastructure. The investors have to get their returns. So that is the other side of the story. And the biggest take that you have given us that we should adopt our businesses to the new business environments to survive and grow. Thank you very much once again, Mr. Harish, for all your inputs. And now let's go to Mr. Uday Dave, who is the Group Financial Officer at KIMS Healthcare Management. I'm sure that you will have a lot to say, Mr. Uday. Over to you.
Happy afternoon. Thanks, Vibhu. Really honor and pleasure to be amongst all the healthcare specialists. I've been in healthcare industry for the last 2 years, learned a lot with, working with Dr. Saidullah. I just stepped down as a group financial officer, but I closely work with him as a financial advisor, and of course, very closely with Mr. Vijayaraghavan as well. I think both Mr. Vijayaraghavan and Harish Manian brought very valid points. I'm the odd man out, being a chartered accountant. I'll put down my points in terms of what we can do very simply. This is something that we have actually done, but long way to go. But we've seen a good amount of results to start with. I think let me first focus on increasing the margins and then goes to the cost. And as far as the increasing margins are concerned, I think there are three-pronged strategy one should adopt in this scenario. One is we have to get to this procedure-wise consumption, or what I call as margins by procedure, which I think while hospitals look at it at 30,000 feet, I think you have to go to the granular level and look at what your margins are. With a quaternary care hospital like ours in KIMS, I think there is, you sometimes lose the sight of the volumes that you're doing in each of the specialty, and your margins could erode. You have to keep an eye on it. What is very given in this industry is quality and the outcomes, unlike other industries, right? They can, in automobile industry, you can pull back the car, but for us, there is no opportunity to make a mistake, or we can't make any mistakes. Hence, quality, ethics, and outcomes are very close, is very given to us. Given that being the reason, you have to keep focus on your entire consumptions by procedure. And here's where I think both the speakers who spoke earlier, technology helps you a lot. Second is renegotiation, and I think both the speakers again spoke, is group purchase capabilities. While you might get 4 to 5% margins volume, but I think what has not happened in the industry is pharma companies all over the world making huge amount of profits. I think that needs to come into us because we are the biggest consumer of this, and the revenues, 26 to 30% of our revenues come out of pharmacy, and hence we should have collective bargaining capability, because this is very important on two aspects, not just the margins, but it is also about the availability. And second is the quality of the medicines. You have various stacks of products that you can choose in the market. So it is very important for organization to kind of bring that kind of a common platform for a collective bargaining. The third one I would say is the inventory management, especially when a chain of hospitals that you run. I think it's very, very important that your supply chain on the back end is very, very tightly knit. Your reorder quantities need to get monitored. I think these are small things, but it makes a big difference for a big organization like KIMS and other large players in the industry. Let me move my focus on value add services that both the speakers speak. Apart from the home care, I think what is very important to bring is a remote patient monitoring. A lot of the items that Harish was talking about moving out of the hospital, I think that is where remote patient monitoring will play a very pivotal role. And I think India has startups have provided a lot of remote patient monitoring equipments. I think we need to support. Dr. Saidullah rightly said that we need to support our domestic players. Of course, there are a lot of Israeli products also which are available, which are very, very easy to use both for the patients and for the service provider. The second, I would say, is a primary care, I think, which is where a great amount of what Dinesh also spoke is opportunity for a public-private partnership. Today, what we lack is the primary care centers, and I think large organizations should partner with government, and government should really support these private people, because 75% of our consumption in the healthcare is provided by the private health providers, and that's something what Dinesh also highlighted. The third one I will say is products like second opinion, tele-ICU, are all which can be boundaryless. You don't need to be drawing a boundary within a particular region, say a Bangalore or a Trivandrum or a Chennai. You can go boundaryless with your services. I think those are the products that one should embrace with doctors like, for example, you have Dr. Vijay Raghavan, who's a cardio specialist, very well-known cardio specialist, can do wonders and can be boundaryless in terms of providing his services. So I think that is where I would say about the innovative model, that innovations and things that we can look at as far as the healthcare industry is concerned. The other area I would come is on the cost. Now, I think our approach has to be two types. Zero-based cost is what I call. You have to go back to see, if you were to start this hospital today, what would be my cost structures? And what happens to many of the organizations cutting across industries, we build fat over a period of time. And this is the right time to go back and do a zero-based cost, which is nothing but, if I were to start this business today of a 200 bed, what would be my ratios on each of the items? It could be manpower ratios, it could be the count of equipments, it could be about the technology that you're going to provide, the money you will spend. I think it's very, very important on a zero-based cost. Let me give you a very simple example. Heat, light, power. Many a times we ignore this heat, light, power. And let me tell you, it's something that we have done in KIMS, and we've got immense success. We broke down the heat, light, power into our electricity, our water consumption, our diesel consumption. And then we said, what is a peak time, off-peak time, and then made a lot of interventions. We also changed our equipments, and this is where Vijay Raghavan sir said very clearly that you have to take a choice of whether you want to invest on this capex, and if it is helping in the long run and saving your running costs, I think you should do it. We changed the entire chillers, and today we are seeing at least a 30% benefit on the electricity cost. We've reduced our diesel cost consumption. Let me tell you an example on water. If you are running the motors in the morning where it is a peak tariff, we've been running the motors in the night where the tariffs are lower. Now, these are very small things, but adds immense cost savings on the table. So this is what I call to my team a forensic visibility of the data. You should not have an accountant's eye on the data at a P&L level, but go further, more drill down, and then break it down. And I'm sure there's a lot of opportunity. I can give you another example on printing and stationery. Hospital industry consumes a lot of stationery, and all that can be reduced, rationalized by use of technology. One. Second, you revisit your office space management, and thereby the printers, and thereby the cartridges. Now, printing and stationery is something no one looks at it from a P&L perspective. Everyone is bothered about the direct cost or your employee cost. I'm not saying we don't look at the employee cost. I'll come to that employee cost. But these are minor things, but they add up to 5 to 6%. And people give it up because it is fixed cost. In my view, we should never give up a fixed cost, saying that fixed cost, can we make it semi-variable? And I think there's a lot of opportunity in doing that. Now, let me go to zero-based organization structure, which is, again, if I were to run the hospital today at a 50, 60% occupancy, what should be the ideal manpower ratios? I think we get bogged down by a lot of the traditional manpower ratios. I think we have to revisit these manpower ratios. Given the cost structures in Kerala is very high, your nurse costs are very high, which got changed the last 2-3 years by a government notification, is one of the highest in the country. I think it is very, very important that you relook at your manpower ratios, be it nurse to bed, nurse to patient ratios. I think this is where you will see a lot of fat sitting, and there is an opportunity to make a rationalization there without affecting your customer service. The other area on the zero-based organization is multitasking. There is a large quaternary care and there is a small tertiary care or secondary care. We need to differentiate how all these three models would work, and accordingly the manpowers need to get distributed. Probably secondary care, a 30-bed, 50-bed, you don't need a medical superintendent and unit head. The superintendent accesses unit head. That's where the multitasking can happen. You don't need a nursing superintendent and a nursing assistant or a nursing manager. You see how you can couple all of them and see how you can do multitasking. And I think that is the way we can get our margins better. The last one I would talk about is the interest cost, which is very high. And I would appeal, FICCI, that this is one industry that needs to be given that industry status, which is what is missing. Recently, I read today morning that Maharashtra has accorded its hospitality companies industry status. What gives you is tax subsidies, electricity subsidies, and a lower interest cost, because the gestation periods of this industry is as high as 10 to 12 years. I think FICCI should put a strong proposition during this time to the government that it be accorded the industry status so that our borrowing costs can come down. If you want to augment the beds in this country, and if you want to reach the hospitalization targets that Mr. Dinesh was talking about, I think the first thing they should come out is provide a very cost-effective financing for this industry, which is missing. The banks don't understand, financial institutions don't understand how a hospital industry works. They don't appreciate the gestation periods that we go through, and I think this is where I would urge an organization like FICCI to kind of put forth. I'm sure Dr. Saidullah has already done that, but I am emphasizing here again this point. And I think the last point I would talk about is the real estate design, and Vijay Raghavan sir had touched upon this, is the capex, the money that you spend per bed is something that you relook. Tier 1 city, tier 2 city, and tier 3 cities. I think there's a huge opportunity with a lot of innovation. For example, you can do mobile buildings today. You don't need to get bogged up with brick and mortar kind of buildings. So these are various opportunities that are sitting, innovations that you can embrace. These are cutting edge technologies and innovations that are available in the market, which the hospital industry should embrace. I will leave my last point with saying that I think FICCI I've been attending various meetings and seminars with FICCI. I think they're doing a great job in pushing the bar in terms of the various support that is required, and also see quality services are reached out to during this time. One last thing that I would leave is GST reforms on the healthcare sector is, I think, not taken cognizant by the government. I think it is very important that take cognizant of this. While other industries are lobbying, I think we should also do the same so that we directly transfer this benefit to our customers because of whom we are actually today surviving. Thank you.
Once again, a big thank you to you, Mr. Uday Dave. You have given us lots of further inputs onto the subject. I think the major take is that, we should have a microscopic eye on whatever we are doing, an eye to detail in each of the verticals within the hospitals, so that we can improve our margins through that. And technology can be leveraged. And once again, you have also stressed the importance of collective bargaining, not only to bring down the cost, but also to ensure quality of the inputs like medicines and other stuff. And zero-based costs is something that is a good take-home, because electricity costs, as an example, if you run your motors in the night, you're going to get further reduction in your electricity costs. Things like that. Even minute details like printing and stationery, office space management, manpower, you've touched everything. Infrastructure costs. and the finance cost, of course. And the major take for FICCI, I think, is that, if there is a bargain or if there's a collective representation from the hospital industry to the government of India for reducing the interest on capital, I think that would serve a long way in increasing our margins without increasing our billings. So thank you very much for all the inputs that you have given us, Mr. Uday Dave. And I think Dr. Alok is not here right now, so I would hand it over. Is he here?
Yeah. People, I think Dr. Alok has already joined for the first session for the inaugural part. Sir, what he has said, he has already conveyed his strong points in the inaugural part. So that's why he has exited from the second part of the discussion. So we can, Alok will not be joining for the second session. It's just informed us. Okay.
Thank you. And so I think from what our chair.
One more thing, sir. For the informational participant, this program is being done at the FICCI Bike platform, where only the speakers will be visible in the platform and rest of the participants will be joining on the YouTube link. So we have got large number of participated by you who are already watching the program and the YouTube link. Only the speakers will be provided in the current platform for the convenience sake of their controlling the platform. Okay.
Yeah. So I would like to thank all the three speakers who have come, who have just highlighted or enlightened us about cutting our costs and increasing our margins without increasing the rates of the billings. And that is what we have to take. And let me just hand this over back to our chair, Dr. Sadullah, because I think you can touch upon medical insurance, medical value travel, and even other like industries in the healthcare sector like Ayurveda and all that for to bring Kerala as one of the most, as you all know, Kerala is one of the states, and we have, I think the per capita health per individual should be the highest in the country. Thank you very much once again to all of you. So over to Dr. Sadullah for kindly summing up once again.
Thank you, Bibu. That was a good session. I think we went through great details about how we can increase the revenue and increase the margin, and that's a good learning. I think each one of the speakers contributed very well on that. The main thing is that, like Karishmanian mentioned, I think we have to change our mindset, and we are not going to be like the old doctors, and we have to change the healthcare deliveries from the doctors mainly, and of course from the paramedical and nurses. But we have to completely change our mindset and adapt to the new innovative ideas, and that's the only way. Of course, digitalization and other things which are going to come in the coming sessions. And so I thank each one of you, and Bibu, you moderated very well. And I conclude the session with word of gratitude to all of you. And Uday, and you went into the minute details of the finance, and that's what we expected from you anyway. So. Because I know that you have got all the numbers correct. Thank you, and over to the next session. Much obliged for your presence in this session. Thank you.
Thank you, everyone, once again. Thank you.
Thank you so much, sir, for the opportunity.
Thank you, all our eminent speakers. We'll move to the next session. And to take over the next session, we have Dr. Sharish Abdullah, Chief Executive Officer of KIMS Healthcare Group, is a moderator for the session. And Dr. Sharish Abdullah is a highly skilled physician with over 20 years experience in clinical medicine and hospital operations. And Dr. Sharish was appointed Chief Executive Officer of KIMS Health Group in 2018. A fellow of the Royal College of Physicians of London, Dr. Sharif is American Board Certified International Medicine and Senior Fellow of Hospital Medicine. And he obtained his medical degree from Tufts University in Boston, Massachusetts, and did his postgraduate training in internal medicine at the University of Washington. Okay, okay. I would request Dr. Sharif Sadullah to take out the sessions, and we have our eminent panelists speakers for the sessions are Sri Padma, Chairman, Managing Director, Thermop and Paul Private Limited, Sri Thomas John, Managing Director, Agapine Diagnostics Private Limited, Sri Balamurali, Corporate Head, Palakkad Surgical Industry Private Limited, and Sri Gautam Ganna, Co-Chair, FICCI Health Service Committee and CEO, PD, Hinduja Hospital and MRC. Gautam will be joining shortly. So we have the three speakers already lined up, and Gautam will be joined by 4:50. Over to Dr. Sharif Sadullah for the proceedings.
Hi, good afternoon, everyone. I hope that you're all keeping safe and healthy, and greetings from Bahrain in the Middle East. Thank you for that introduction. My name is Dr. Sharif. I'm the CEO of the KIMS Group, and a special thanks to FICCI for organizing this event. And a lot of people have said it's a rather timely event. And I got a text, this WhatsApp text this afternoon, and there's a lot of things going around social media, and it was that today is it's a little bit of an ominous anniversary, but apparently today is the anniversary of the first case of coronavirus that was reported. And it was reported in the Hubei province of China, even before the cases were started to be reported in Wuhan in the earlier mid-December. So we've come a long way in the last year, and I think there's been a tremendous impact, as we've heard, in terms of the pandemic. We've heard that today. We've all experienced that, and it's had an impact on all of us across all industries, even in healthcare. And we've all had to learn how to do things differently. Even the way we deliver healthcare, have to learn to do that differently. For us as an organization across India and the Middle East, our patient volumes were significantly reduced, 50% in most, even in some of our Middle East regions, even a little bit more. And I think as we slowly emerge from the pandemic, or at least we learn to live and survive with the pandemic, we as healthcare organizations are really reevaluating where we will all fit into the new healthcare scenario. Now, routinely, we use the word healthcare, but in reality, it's not what we're quite doing. What we're largely practicing is sick care and or acute care. And I think there'll be a real transition in this post-COVID era from sick care to preventative care. And we've heard a couple of the speakers talk about preventative care or wellness. And perhaps even on a larger scale, what we refer to as population health. And population health really refers to the general health of a community or of a state or even of a country. And I think we really need to look at a data-driven approach to improving health outcomes. I anticipate that there will be a need for government to increase their spending on healthcare, at least as a percentage of the GDP. And I think that this will lead into greater public and private partnerships. I think this has to happen. There'll also need to be more of a private collaboration. So perhaps a greater collaboration between some of the larger quaternary and tertiary care facilities and the secondary and primary care health centers. Really, primary care is at the center of what we refer to as population health. And as healthcare providers, we have to really look at having a greater community presence. I think volume of patients that come to the larger hospitals is only going to decrease. But patients with more acute issues or more complex issues will need to be seen at these larger facilities. But routine care should really be looked at being provided locally. Over the last 6-8 months, healthcare has also needed to change and adapt technology. Harish mentioned about the Cleveland Clinic and the use of telehealth. Even before the pandemic, Kaiser Permanente, it's a healthcare system out in California, they did more telehealth last year than they had physical visits. And so there'll be a change in terms of point of care. And I think that'll take a new meaning, and we'll be shifting from hospital-based services to physician offices or in-home care, and really decentralizing the care. And the digital health that we spoke about is just a part of that. Until this pandemic, we always used to say that the world is getting smaller and we're all interconnected, but we could travel easily, we could order products from any country. And in the post-COVID era, another situation that's going to arise is that the trust will sometimes take some time to come back. The logistics will take some time to come back. So we may be really looking at more local products, local activities, and purchasing locally will have a definite cost benefit. And as we've heard, we need to look at how we can better develop affordable care. So I'll just stop here and we'll start our discussion on really the strategic alliances with larger hospitals, the Make in India initiative, and the digital health platform. I welcome all of our speakers. I'll give a little bit of background of each one of them as they are about to speak. Our first speaker is Mr. C. Padmakumar. Mr. Padmakumar is the chairman and managing director of Thermopo Penpol Private Limited. He started as a junior project executive and worked his way up in India's first blood bank company, the Peninsula Polymers, otherwise known as Penpol. The company is now established as one of the largest manufacturing sites for blood bags in the world, and is a market leader in India with a presence in over 80 countries, or products being sold in over 80 countries. So welcome, Mr. Padmakumar. I'll turn it over to you.
Thank you, Sheriff. And I assume that I make a few introductory remarks at this stage, and then is that the way you want to?
Yeah, I will. Each speaker will have about 10 minutes or so to allotted time for them. We'll go through all the speakers, and then if there's some questions, or we can have a few discussion points afterwards. I think there's an opportunity for the audience to also ask questions. So we'll invite questions from them, or a few questions that I may have.
Yeah, sure. Thanks. So I must say, when I saw the topic first, strategic alliance with larger hospitals in connection with the Make in India and Digital India programs, I was initially a little taken aback. But then on further thought, it struck me that this is actually, whether by design or default, a very relevant topic. It's very relevant for hospitals. It's also very relevant for the medical device industry, of which I am a part. Small correction, Sheriff. I retired as chairman and managing director of Thermo Penpol in March, after having served the company for 35 years. And currently, I am a director on the board of the Kerala Life Sciences Parks, which is set up by the government of Kerala. So, let me start with looking at it from the viewpoint of the medical device industry. And there is a very significant difference between the way the industry approaches business here in India, as opposed to how it is done in many other parts of the world. I'm not going to take a global view, I'm going to restrict my comments to the one geography I think that most of us know about, and which is obviously the world leader in devices, which is the United States of America. The United States is far and away the leader when it comes to medical devices. And I think it will be interesting to understand why that is so. You know, is it an accident of history and geography, or was there something more to it? It's a very instructive paper published by Michael Porter and Associates. I think this came out something like 10 or 12 years ago, and it's worth reading. It's about the Minnesota medical device cluster. So what Porter and Associates have done is to look at what are the factors that go into driving the success of the medical device industry itself. And he believes that a key factor is the cluster. Now, what is a cluster? You need a large teaching hospital. You need a university. You need enough engineering talent, which presumably means a good supply of engineers and maybe engineering colleges. You also need a reasonable sized medical device company, all in the same location. The magic happens in the interaction between these different agencies. And I think I don't know if this is well known or not, but you know, every medical device company talks about innovation. The ones who talk about it most are the large multinational companies. But the fact is that they don't do much innovation. The innovation is actually done in the universities. It is done by startups which are associated with these universities. And the way the business is structured in the US, many of these get bought out by other companies. So this, if you can call it an ecosystem, comprises of all these elements interacting with each other. And it is this interplay which actually gives us the innovation, the research, all the new fascinating stuff that we see in healthcare. So I'm going to confine myself to, I know that Sharif talked about you know, healthcare and maybe you can call it disease care. I'm not going to get into that debate. I'm just going to speak about the way healthcare is currently practiced and with specific reference to hospital care. Now, I've described the situation in the United States. So they have a flourishing system like this. They have at least 20 clusters, including Minnesota. You've got San Diego, you've got Boston, you've got Pennsylvania, the Raleigh, North Carolina, so many of them. In India, we actually don't have any clusters. And there is very little interaction between industry, hospitals, and academia. Now, this is not unique to healthcare. It is, I think, what shall I say, a feature of Indian industry in general, the fact that we don't seem to believe in investing in R&D. And that is greatly to the loss of our people and our industry. There are some small signs of change. I hope that we're going to see a lot more in terms of Indian industry taking the lead and working with hospitals. Having said this much about the medical device industry, let me also turn my attention to hospitals. I am not an expert on hospitals, except for the fact that for 35 years, I've been selling to hospitals. So I have some knowledge of the way in which they work. I have an outsider's viewpoint. And I must say that the situation is a little disappointing with respect to hospitals also in our country. Unlike the Mayo Clinic or the Cleveland Clinic, Johns Hopkins, and dozens of other big hospitals that we can talk about, I can't think of too many hospitals in our country which have an active research and collaboration program with industry and with academia. I am not going to get into who is at fault here. Let's just say that industry is suffering, hospitals are suffering, academia is suffering, and certainly the patients are suffering as a result of this. I can name a couple of honorable exceptions to this rule. The hospitals that I've seen which are really different in this respect, in the sense that they believe in research, they believe in the fact that they need to drive innovation in industry by sharing their knowledge and expertise with industry. The examples that I've seen are, one is Sri Chitra, but I think that is, by, what shall I say, by fiat. That is the way that hospital and that institution is constituted. They are supposed to be half research and half hospital. The two other good places that I've seen are, one is the All India Institute of Medical Sciences in Delhi, and the other is CMC Vellore. I wish that there are many more such hospitals which open themselves up, because today, if you look at a hospital, I mean, what is it other than the factory floor where we are actually doing a lot of intervention, we're bringing in sick patients, and we're trying to treat them and cure them. And we, as a result of the processes which happen in that hospital, we have access to a lot of knowledge, a lot of experience, and a lot of data. Now that is, I think, being grossly underutilized in our country. So I believe that there is a huge opportunity. We have very little interaction going on between these three, that is academia, hospitals, and industry. Let me stop here, Sheriff. I'm sure the other speakers will have a lot more to say on the subject, but these are my two key points. Thank you.
Thank you, Mr. Padma Kumar. Sorry about the error in the introduction. I went by the profile that I received. But thank you for your insights. And I think we'll probably come back a little bit later after the sessions to talk about the medical devices. And you said, USA is a leader in medical device manufacturing. But, how can we get India to become that leader, especially since we're able to do it in a cost-effective manner compared to perhaps the States? So we'll come back to that, but just keep that question in mind and we can have a discussion around that. Sure. Thank you very much. Our second speaker, I don't know if, has Mr. Gautam Khanna joined us?
Gautam has already joined.
Okay, great. Thank you. Sorry, I can't see everyone. Welcome, Mr. Gautam Khanna. Mr. Gautam is the co-chair of the FICCI Health Services Committee and the CEO of the PD Hinduja Hospital and Medical Research Center. He's a mechanical engineer initially and from IIT, and subsequently went into business administration at IIM Calcutta. He started off his career with the RPG Enterprises in Mumbai and continued to work there until 1992. In 2014, Mr. Gautam joined PD Hinduja Hospital and MRC as their CEO. And as the CEO, he endeavors to achieve Hinduja's dream of virtual healthcare by impactful innovation and creating synergies with leading international institutes. So thank you for joining us today, and I'll hand it over to you.
So thank you, Mr. Sharif. And I joined and I was fortunate to hear Mr. Padma Kumar's comments on that. So I was going to, I have a few comments on that and then I will talk about. So one, I have to say that I think it's very important for hospitals to focus on education and research both, because like you said, there is enough data on which can be used for research, and there's enough opportunity to educate, the younger doctors. So I think all hospitals need to have some side which focuses on research and academics, and the reason for that is that it also improves the clinical patient outcomes, because when the clinicians and consultants and nurses and everyone is focused on academics and research, they study, they learn about best practices across the world, they learn what's going on, and sometimes those are implemented in the patient care. So I think that's a very important aspect. The other thing, I think there is a lot of opportunity for alliance definitely in the country between different groups of hospitals, between hospitals and device suppliers, and for example, pharma. For example, even in US, you probably know that there are groups which have tied up with each other. For example, Tenet has tied up with Yale New Haven. Then Cleveland has tied up with I forget the name, Community Health Systems, and then Duke and LifePoint have tied up. So what they are doing is the different hospital groups are tying up. Some are for profit, some are non-profit. One is either to get the reach, and the other is to get the academic component into the for-profit component. So I think that kind of synergy is possible within the country. Mr. Sharif, you mentioned, but I think 22 years of my work ex, you kind of skipped on it, but that 22 years I worked in 3M, and that is a medical device company and in a medical consumables company. So I've worked there, and so I understand the opportunities which those manufacturers have with the hospitals. And because both of them, if they talk to each other, first is if they talk to each other and then they collaborate, you can get a better product. So for example, our clinicians have specific needs, which may or may not be the need of the American public or the American hospitals. It's the need of the Indian doctors. It is required for Indian patients, and the Indian companies can do it. So I think there is a opportunity for collaboration between hospitals and the suppliers. The other thing is, if you have a tie-up, some kind of an alliance, there is a hidden aspect to this, which is that it gives the access to it's an excellent source of talent, whether it is for doctors, whether it is for researchers, so that both parts of the ecosystem get access to better talent, they can do better research. And if I can say that, in my experience, we've been trying that in the hospital a couple of times. We talked to many of these guys who are the startup people, and sometimes, of course, to encourage them, and many times they have excellent ideas. And we have seen, when you talk to them and we kind of have an alliance with them, my patient outcomes and my patient experience improves. So it is a big win-win for me. It's a win for me as a hospital. It's a win for them because they get access to the people like us who become their referral and centers and the referral benchmarks. The other thing which we miss out many times in this alliance kind of thing, and one thing which COVID has taught us, in that in the last 9 months or 8 months, all of us in part of the ecosystem, whether it's hospitals, device suppliers, labs, consumable companies, NGOs, government, everybody has worked together and given the care to the patients. So everyone has collaborated. And I think there is a lot of opportunity to continue that collaboration. So for example, the lab chains, the diagnostic lab chains, maybe they can partner with hospitals for, to provide telemedicine solutions in the remote areas where they have collection centers. That's a possibility. There are things like, home care services, IT services. And I mean, I can go on and on, but I think there is a lot of opportunity. The key thing there is that, of course, we have to understand that a for-profit company will do a project or a research or work for the ultimate objective of making a product which can be sold at a profit. So that, I think, some of our hospital friends and clinicians also need to understand that they will not do anything without profit. So there has to be a win-win, that the product which meets, or any alliance which meets the needs of our clinicians and a hospital in delivering better patient outcome, and also helps the other partners survive and meet their objectives. So I think there is a possibility, and I am completely in support of that. And I'm going to stop here, Mr. Sharif. Over to you.
Thanks, Mr. Khanna. So I think what you were largely talking about is, integrated health systems, and how can we establish better integrated health systems, because it may not be possible for a single hospital to be everything to everybody. And we need to look at the spectrum of healthcare delivery from primary to secondary, tertiary, quaternary, and even there's probably a void in India in terms of post-acute care. And now we're seeing a greater emergence of home care, and we can touch on those topics as we go along. So thank you very much. Our third speaker today is Mr. Thomas John, Managing Director of Agape Diagnostics. Agape Diagnostics was born in 1994 in a factory premises in Mumbai. And it was started by Mr. Thomas John along with family members as co-promoters, and he's developed it over a period of time into a world-class manufacturing unit now in Kochi, and it's one of the biggest in India, over 20,000 customers supplying over 66 countries. So thank you, Mr. Thomas John, for joining us today.
Thank you, Dr. Sharif. Thank you, Fiki, for giving me this opportunity. I am Thomas John, Managing Director of Agape Diagnostics Limited. We now based at Cochin. We started from Bombay, as Dr. Sharif mentioned. Today, the subject is strategic alliance with the larger hospital line with the Make in India. So since I am totally connected to the laboratory diagnostics, as a true manufacturer from India, I can give you some inputs connected to the laboratory, what way the strategic alliance with the large laboratories as a local manufacturer. You know, before coming to my insights, I just wanted to give some of the data where Indian healthcare market is nearly about 2 million crores, where we comes under medical device. Again, medical device is about 7% of that 2 million, which is about 150,000 crores, where IVD, that is in vitro diagnostics or lab diagnostics, is just 10,000 to maximum 12,000 crores. So you may wonder that the laboratory diagnostics today's scenario, it is so important, but the total market is so small. And again, one more data is more, I would say that very, very promising, I would say that, because India is the country where more than 25% of the population lives, where in the IVD business, we are just 1.2% of the world IVD. That means world laboratory diagnostics. So you can understand that Indian laboratory diagnostics is so small, and there is a great opportunity where we can grow. I would say that in the pupil's perspective, diagnostics is just 10% the cost of treatment. So if you have a proper diagnostics, there is a huge scope of reduce the cost of the treatment. Now coming to the Indian diagnostic scenario, we can classify about 4 types of laboratories: A class, B class, C class, and D class. Mainly A class and B class, they are located in the Tier 1 and Tier 2 cities, where the C class and D class, they are based in Tier 3 cities, where the classification of A to D depends on the number of tests per day, where big hospital, corporate hospital, where more than 5,000 tests where they are conducting means, it comes to the classification of A class, where D class is something around less than 500 tests per day. Now, mainly A class and B class, C class, they're having, very, very highest level of automations, which are provided by, multinationals and Indian big manufacturers. Then mainly the C class and D class laboratories are in the Tier 3 cities, where 70% of the population and more than 60% of the laboratories are located in the rural India. So it is so important for Indian perspective, the Class C and Class D type of laboratories, where the automations are always minimum, or I would say that less than minimum. Now, this is another big opportunities, because the reasons, the current scenario, A and B class diagnostic centers are fully depends largely on the automation systems, and that too from multinational companies. Ironically, majority of these instruments are manufactured mainly in Japan, but this is again transported to the Western world, where the MNCs are buying and they are adding with the consumer, which are the reagent, and coming back to the countries like India. So the lot of costs are involved in that. So the price is always much higher. So majority of these systems, even the multinational companies, are providing on the rental way, where the price of the consumables are also very high. And now, because of the competitions these days, the rental systems, mainly the multinationals, are providing as refurbished instruments, where they wanted to reduce the cost of the instruments. And majority of these multinationals, again, they are focused in the tier 1 and tier 2 cities, because of the less manpower and because of the less penetration in the rural India. And there are good local manufacturers. They are based in India. They have they're having good automations in the laboratory diagnostics, and they have very good penetrations to even rural India, especially tier 3 and tier 2 and tier 3 cities. The local manufacturers having the other advantage today, I would say that they have very strong distribution network. India is such a big country where they will be able to give on very good support service in terms of hardware, and they have good distribution network for timely availability of the consumables, which are reagents mainly. Now, the way forward, where how the local manufacturers, how they can associate more bigger way with the large hospital. I would say that the corporate hospitals and the domestic large manufacturers, they need to have a lot of I would say that tie-ups for clinical evaluation and validation of assays which they develop. Then tied up with satellite centers of high and medium hospitals or diagnostic centers, because now these days most of the diagnostic centers, they have a lot of satellite centers where probably most of them are from the remote areas where the domestic manufacturers, they have the reach. Then a lot of associations in the multiple segments to reduce the import dependency. I can give with one of my own story, where we have three or four types of products we have developed domestic. One is that the hematology systems, 3-part hematology. Recently we have launched first time in India. About 15 to 20,000 instruments are coming to India. But all these years, this 100% of these instruments are imported. Now we made a good tie-up with one of the big technology company, and we brought these products to India. Similarly, a lot of things many companies are doing in terms of immunology systems, clinical chemistry systems, which they always develop by looking at the Indian conditions or developing countries' conditions. Then a lot of preference we need to give to the local manufacturers for the public-private tender systems. Of course, now government these days, they are giving a lot of that sort of preference, and so that way the price of the cost of the diagnostics can be reduced. And recently, there are a lot of PPP projects are available where there should be a good participation should give to the domestic manufacturers. And as I mentioned that the hematology systems. Similarly, now in the COVID scenario, the real-time PCR systems, it's 100% imported systems because nobody is manufacturing here. And I'm very happy to share that last week we brought the first lab-based COVID confirmatory detection systems. This is the first time in India that will reduce the cost by, I would say that 1/4, even the real-time PCR. Real-time PCR, the cost, the initial investment will be about more than 10 lakhs, where here in UK it's about 3 to 4 lakhs. Then again, there are a lot of technological advance. This I just I wanted to give as an example, but a lot of Indian domestic manufacturers, they are working on this sort of technologies where, you know, the large hospital can work together, where we can reduce the cost of the diagnosis, and the same way that can give benefits to especially rural Indians. That is what I would say, that because always I believe that India's lives in the rural India, so where we will be able to give a good support around. Now, one of the main things which I wanted to touch that, as I mentioned, that the cost of diagnostics is just 10% of the patient treatment. But whether the hospitals are giving that much importance to the, you know, laboratory or diagnostic centers, these, if we can give that, definitely, you know, that can give definitely big benefit to the public. And proper diagnosis is a key factor, and give little more importance and give more infrastructure to the, you know, the laboratory diagnostics, which can always help for the public. This is what I strongly believe. So even Agape also, even the company which I'm associated, you know, we have a lot of you know, small to bigger systems which can be associated with even big laboratories also. So where what we are doing is that we may not be manufacturing the big systems, but we are associated with some of the big equipment manufacturers from Japan and all, but consumables, that is reagents, which we manufacture locally, where we can bring down the cost in a very considerable way. That is one of the main advantages. Second, the biggest advantage these days, these IoT based or patient data is very, very important. So whoever may be the solution provider, they have to always keep the data very, very strictly confidential. And so always it is better to associate with a domestic manufacturer, domestic supplier, so that the data always will be within India. That is always, it's very, very important. So these are the main things which I wanted to mention about the laboratory diagnostics, the way like it can be associated with the large hospital. So thank you once again. With this, I conclude. Thank you, Dr. Sharif and Fiki, for giving me this opportunity. Thank you.
Thank you, Mr. Thomas. I think diagnostics, especially in the post-COVID era, is going to be an integral part of healthcare. And I have some questions around that. We'll come back to you after our next speaker. I welcome Mr. Bala Murali. Mr. Bala Murali is the corporate head of PSI. PSI stands for Palakkad Surgical Industries. PSI is a Kerala-based manufacturer of surgery equipment and a nationwide leader in surgery positioning. Bala leads the company's product strategy as well as oversight of the corporate decision-making for PSI. So thank you, Mr. Bala, and I'll hand it over to you.
Thank you, Dr. Sharif. And I'm afraid I was, you know, as another speaker before me was mentioning here, I was all prepared to talk about clusters and university sort of partnerships and things like that, but it looks like it's going to be flogging a dead horse. So, you know, I'm a little unprepared now, but I'll try to keep this brief. It's probably best that, you know, we are at the tail end of the session, and maybe I'll keep myself brief because Dr. Khanna and Mr. Padma Kumar, they all spoke about some of the stuff in great detail and you know, with great depth of opinion there. Our company, as you briefly mentioned, we have been a you know, a device manufacturer, equipment manufacturing company for the past 60 years. I, in fact, am a substitute speaker. My managing director was the one to speak today. He could not make it, so I am speaking on behalf of him. So he would have been, better positioned to talk about the history of the company. But I think it'll suffice to say that we have. We are what we are today because we have been an Indian manufacturer that sort of was early to the frugal manufacturing party, if you will. We have been able to produce back in the day what we would call import alternatives, import substitutes for surgery equipment. We've been around for 60 years, and a good 30 years of those 60 years we've been making operating tables. And I think we make what is considered the better substitute in operating tables in India. Now, that said, that's a very small niche market, and it's sort of it sort of jives with the type of make in India things that we hear being talked about every day. The reality, though, that we are often faced with is that make in India, very often seems to be the least resistance, cheapest way to making an alternative solution available in India that probably a foreign manufacturer offers at a much larger premium. And that is what our company, and I'm going to talk about problems more than opportunities, it looks like, and that's the type of problems that a company like ours finds ourselves in every hour of every day. The type of partnerships, the type of investments into basic sciences that are not present in India causes issues even for something like ours, which is not a really high sophistication set of products that we create, but things that have a very high impact on a very high revenue, high stakes environment in a hospital, the surgery room, and yet the availability of the non-availability rather of material science expertise locally, for example, or semiconductors, or things like that, are real headwinds as far as a company like ours is concerned. With that, over the past 3 to 5 years, we have tried to sort of look for an opportunity in that existing market in terms of bringing things together, in terms of integration, in terms of thought leadership, and in terms of leading from a process standpoint, be it sterile processing, where I think it's not as talked about as much as non-communicable diseases, but sterile processing seems to be seems to be what should be a high focus area, given the amount of hospital acquired infections, especially from the operating rooms that we have today, and how non-standard it is across hospitals in India. So for a very long time, we have been in that space making sterilizers, but that seems to be something, making better sterilizers is something that we constantly invest into. We try to make it better. We try to adopt high quality components, high quality technologies that sort of develop as they do every 5 years or so. But we have sort of pivoted in the last few years into going from making better equipment rather than to provide better value for our customers, which are these hospitals, and our value is centered around the operating room anyway. So that is sort of a segue into having these digital capabilities. A lot of what goes on, a lot of this, I think a gentleman before me spoke about, I think what he called, forensic level data. all that data that is being generated in India with the amount of the volume of services that we deliver every day, that should in and of itself be able to produce meaningful, context sensitive, relevant information in terms of bettering processes. And that's where in my personal opinion, that we have an edge over, let's say, somebody in the US or Europe. They have mature processes, they have grown slowly, and we are moving very, very quickly. We are making mistakes, and the problem, in my opinion, is that we may not be learning as much from our mistakes as we should be. So, our company, we have tried to sort of go in and see if there is an opportunity there, investing into IT systems, process systems that can then, use all of that data, regardless of, the context, sterilization, or, operating room information, all of that stuff, and come up with meaningful information that can then be used to deliver better care. That is one. And while we were making investments into that, we had a team, so we might as well use them. So we also invested into making sort of this machine readable, artificial intelligence capable electronic medical record systems. So that type of thing. That by reducing the amount of time that current day systems make the clinicians spend on the computer or doing non-clinical stuff, we've focused on trying to reduce that, and then generate that type of data that our artificial intelligence systems can then look at, and perhaps in the next decade, as we build some depth of data, be able to inform medical research on be it non-communicable diseases or community health, population health, all that type of stuff, to be able to let hospital systems then generate data out of these types of systems, and then contribute into the healthcare system in a meaningful way, in a manner that is relevant to the Indian environment. I did start out by talking about university partnerships, and the thing that we have seen is that while there are grants available that university research organizations, departments are willing to work on, the lack of organization within the manufacturing industry locally, and even the general MSME and government schemes that make those types of partnerships possible, those being very broad-based and maybe a little bit disconnected from the grant systems, again, make it a little bit difficult in how we respond with what we can do then with those grants, or how we partner with these organizations. So a good example of that is just a few months ago, 6 months ago, I believe, when we started going down this lockdown and COVID control protocols. There were a number of student bodies, universities, industry bodies, sort of quasi-political organizations, sort of coming together and saying, well, we have money, let's see how we can use the industry that we have at our disposal to make the best use of it. The problem is that we did not really have those partnerships in place. So by the time we got our gears sort of moving and engaged, it was we did not have a lot of room for actually coming up with meaningful, really useful interventions. Now, we have gone through that experience, and I'm sure that COVID and whatever we're going through right now will sort of open our eyes a little bit better into how we need to have those systems in place. And I the thing about me is I've come from the Raleigh cluster, so I was I was part of how the fintech sort of transformation that happened in the past 10 years. I was in one of these clusters working with universities, leading up, for example, iterative development, which is something that is very, very, very recent. So I'm trying to bring that into our own organization, but on a large scale. I think we have a lot more to do in terms of industry university relationships, in terms of public policy and funding of some of these initiatives that need to be thought about at more seriously at a better depth. And Make in India should really mean making better equipment, better solutions, high quality interventions, rather than indigenization of really low tech technology. That's my opinion. Again, I'm all the speakers before me had such great things to talk about, and I sort of come in at the end and I don't have such a positive view of this, but I'm sure that this is a transformative period that we have all learned from what has happened and what has accelerated our thought processes in these regards over the past 6 months. And I'm sure the next 6 months and the next year will have better things in store for us. And I thank Vicky for giving me the opportunity to pessimistic as I am right now, but giving me the opportunity to speak about these things. And thank you all.
Thank you, Bala, and thank you to all the speakers who gave their insights today. We do have some time for questions, and the chat box is open for the audience to ask some questions. We've heard a lot about integrated health systems, about manufacturing in India, about expanding diagnostics in India. So it's a great insight on how we can look at healthcare going forward in this post-COVID era. I'm going to read out a question, and this really can be answered by anyone. Question is from Mr. Balagopal Chandrasekhar from Kochi. I'm just going to read the question out. Cost is the elephant in the room for healthcare, especially in India. Devices developed for global markets are priced out of reach. This sharply restricts their usage. The example given was the syringe pumps and infusion pumps, which is about 4 per surgical bed globally. It's a small fraction of that in India. Indian industry and hospitals should aim at developing products that make economic sense in India. So we've talked about manufacturing in India, and so what's your thoughts on really this question and the economic viability? Because I think there's going to continue to be cost pressures, insurance pressures on healthcare in India. And I'll open it up to our panelists.
Dr. Sharif, can I take a shot at it a little bit?
Please. Yeah.
So I just wanted to convey to Mr. Balagopal that it is, of course, it is expensive, but we have to understand that my personal philosophy is that a human being is the same whether he's an Indian or an American or a European or a Japanese. So there is no reason why an Indian should not get that high level of patient care which he deserves as a human being. So I think that is the first thing you have to understand. And second, if there is a high quality product, we should try and use the high quality product. I can understand the affordability, so I'm going to come to that in a minute. Now, the easy answer to all this, people say, is that why don't you make in India? But you have to understand that when you make in India, you don't get the global economies of scale. I mean, so you can never make that cost. And even if you can, you would have compromised on some feature which is available to international patients, and why Indians should not get it. So I think the solution to this is what I would like to convey through this forum to the audience, is that our people do not have enough, either they do not have insurance, or they are underinsured. So for example, now we know that a major procedure, and many of us will undergo a major procedure in their lifetime. It is not going to cost 2 lakh rupees. It is not going to cost 1 lakh rupee in a nice tertiary care hospital like yours in Cochin. It's not going to be. So, but if you are insured for 2 lakhs, and if the bill comes to 4 lakhs, you will say hospital is expensive. But if you think about it, when we buy a motor car, we buy a vehicle, we do a compulsory insurance, and we pay a lot of money for that insurance. Why don't we pay that money to insure our body? Health insurance is a must. All of us need to ensure that people take health insurance, adequate health insurance. And it's okay. People in India, we have a tendency that I am never going to use it, so it is a waste of money. I am saying, let it be a waste of money. Better to have the insurance and be healthy so that you can never use it. But I think that is the main point which many people in our country miss out, that insurance and affordability and willingness and the ability to pay needs to be enhanced, and extra effort has to be done to pay for healthcare cost. We cannot just keep compromising on the quality because I want it lower cost. Then one day the cost will go only in a lower downward spiral and quality will completely be at the bottom. I think we need to stop somewhere. So that's my view.
Thank you. And any of our other panelists would like to add to Mr. Gautam's comments?
Yeah, may I add my comments, Sharif?
Please go ahead.
Yeah, I have a slightly different take on the subject. And while I think Gautam has made some very valid points, I'm speaking purely as a manufacturer here. So I'm not getting into the demand side, okay? There are two aspects to manufacturing. First is what are you making? The basic product. So I don't think, and I completely agree with Gautam here, that wherever you are in the world, you should have access to the exact same quality. So that's number one. Making domestically does not, in my opinion and my book, mean you're making some third-rate substandard stuff, which unfortunately is what is happening in a lot of domestic companies, with honorable exceptions. Because unfortunately, and this is not just in healthcare or medical devices, this is across the board in Indian industry. That's a sad fact. We can keep talking a lot, but I think if you're prepared to face the facts, and if you're not prepared to face the facts, I don't see how we're going to improve. So I think number one is there cannot be any compromise on quality, and we have to follow international standards. Now, having said that, we come to the next question, which is about cost. Now, it is true that there are products which are probably over-designed for a specific market, or maybe over-designed for any market. And a lot of the devices that we have, frankly, in my opinion, are. So this means you have the exact same function, the exact same standards of quality, you're using the same high quality of materials, you're not compromising on anything. Except that maybe you cannot do some, feature, or you cannot add something which may or may not help in terms of patient outcome. So I think that's where the issue of cost and affordability comes in. So speaking as a manufacturer, I believe the first and most important thing, which we have not done, we are making a big mistake in this Make in India thing, thinking that just by making in India, we are solving some problem. We are not. If we don't have international standards of quality, we are asking for trouble. That's my view.
Thank you. Mr. Thomas or Mr. Bala?
I would like to.
Yeah.
Go ahead, please.
Sharif, there are two more questions also posted here. Yes.
Yeah,
I'll go with a very short observation. One of the things that about cost. So there is and I think that's what I was focusing on. On when I was talking about this stuff. We have really low cost, cheap stuff, and then we have really expensive imports, and then we have all these rebranded Chinese, type of. Chinese does not mean bad, but Chinese imports, which is essentially copies of somebody invested something that somebody invested real research and development efforts in the US or in Germany or someplace like that. Now, the problem with Indian manufacturing, again, I am coming in as a manufacturer here, is that while on one hand we are talking about making really high standard stuff in India, our testing and certification costs are probably as much as it is in a developed Western economy. What that forces us to do is to then put in these imported Chinese components, for example, into making something really high quality in India, because building our own, getting it tested, getting it through the door, getting it certified, makes it as expensive as something that somebody would have already broken even on in the developed economy. So it's a little bit of both. So the cheap stuff comes out because we do not have testing facilities and other things in India. We have Make in India, but not the infrastructure to go with it.
Thanks, Bala. But don't you think that, even from a cost perspective, if we compare US cost of production, even forget the research and development, but the cost of production itself, that the same quality things should be able to be made in India? We heard Mr. Padma Kumar saying that with few exceptions, that quality may not be there. But can we not provide quality at an affordable cost and become a better, bigger player in the global market?
Yeah, is it a question to me?
I'm just throwing it back out to the crowd there. Go ahead, Mr. Thomas. I didn't give you a chance.
In the laboratory diagnostics, I just wanted to mention that we brought a new technology of nephelometry about 10 years ago, where today COVID prognosis like D-dimer, ferritinol, the product which we manufacture here, and we are supporting about 80% of that. When we brought this product, the competition was from biggest to multinational. It is a 100-year-old technology. What we have done that, we have re-engineered the product for Indian conditions with international standards. Actually, we spend about 5 to 6% of our revenue for R&D for the re-engineering with Indian condition or developing countries nature. We don't develop any products for US, but we develop products for Asian countries or Africa or rural India. So that the quality is always benchmarked with the international quality, because otherwise these are all very critical products. So I think we can easily maintain the same quality where international standards, and the price can be, maybe the cost of the product can be 1/5 or 1/6 or even more. So it is easily possible. Only thing is we need to have the infrastructure, we need to have the ability to spend at least a good amount for the research and development. If these two things are there, then we can bring a quality product.
May I add something, Sharif?
Yes, please.
On the same subject, I agree with what Thomas has said. Let me give you a very specific example to answer your question. Terumo Corporation, which is a Japanese company, has blood bag factories in different countries. So they actually had factories in Japan, China, Vietnam, the United States, sorry, not in the United States, in Northern Ireland and in India, here in Trivandrum. Now, internal assessments show, very reluctantly, finally, our head office accepted that the best quality in the world among all these plants was from here, Trivandrum, and the lowest costs. So I'm saying there is really no contradiction. You know, if you have high quality, actually you will have, but at the same time, I am cautioning that we shouldn't compare some substandard stuff and allow it to be sold. So I think the regulators in this country have signally failed in their job in allowing a lot of substandard products to be sold. Many of them Indian manufacturers, but I'm sure there are many foreign products also which are slipping through. So I would argue that what we need is better and stronger regulation here. And I agree with what Bala said, see, medical devices in particular can only succeed if the ecosystem is right. All these things have to come together. So just by bringing in some cheap labor, you're not going to get any alternative at all. So basically, that's the point I wanted to make. Thank you.
Thank you. I will move on to our next question, and to, I think the way to look at this overall, and we talk about value-based healthcare, and value-based healthcare I define as cost over quality, and that's really what value is, which is cost over quality. And I think that can be applied for even medical products. So the next question is, what are the steps needed to build industry-university relations to promote collaboration? How can you help? What can FICCI do?
Dr. Sharif, can you just speed up the proceedings also, because we have all the speakers for the next session also lined up.
Okay,
also.
so, okay. Yeah, definitely. Yeah. We were running early in the session, so that's fine. We can, if perhaps Mr. Kanak, would you mind tackling that, being part of FICCI?
Yes, I can talk about that. I cannot speak on behalf of FICCI, but I can just say that at FICCI Health Services Committee, we have, we have the membership of all the healthcare providers, and we have seen the interest from people. So we have, for example, from academia, even from IIM Ahmedabad, we have people who are interested in health policy and health education. They're part of the committee. So there is an interest, but I think the key point is, I should have said that earlier. The key point is that any alliance and collaboration can happen if the two sides have the same values and the same principles, and they want to achieve the same objective. So I think that is the important thing. So I'll give you an example. That this is my not FICCI example. This is my personal example, my Hinduja Hospital example. So we work with IIT here, and our clinicians work with them and trying to develop products for the Indian patients in collaboration. So there is a lot of exchange going on with them. So similarly, there are other hospitals across the country who are doing this kind of a collaboration. So FICCI at a country level, I guess, can only facilitate that. If there is a collaboration, they will support. But I think each individual player will have to take the first step to contribute to this. Dr. Sharif.
Okay, thank you. I think we may be running out of time. I thank all of the speakers today on the panel, Mr. Padma Kumar, Mr. Gautam Khanna, Mr. Thomas John, and Mr. Balamurali for both their time as well as their insights on the challenges ahead. Thank you, and Savio, I'll pass it back on to you to start the next session.
Thank you.
Thank you, Dr. Sharif Chaudhary, Group CEO, KIMS Health Services, for so wonderfully handling this session. Also, I'd like to thank all our eminent speakers or the panelists who joined for this session. Thank you, sir. We are moving to the next session. That's a session on the post-COVID opportunities in medical value tourism. That's a very important session from the Kerala's perspective. And to take over the session, we have Dr. Sri Sanjeev Sanjeev Kurup, President Ayurveda Promotion Society, and also is owner of the Ayurveda Hospitals and President Kerala Ayurveda-based Promotion Society. And he has been recently appointed as the chairman of the newly constituted Ayurveda Tourism Task Force of FICCI. So, Sri Sanjeev Guru would be taking over the session. But so we have very important eminent panelists of speakers. Start off with Dr. Harish Pilla, Chair, FICCI Medical Value Travel Committee, a member of FICCI Health Services Committee, and Dr. Geeta Krishnan, India Representative Ayush, who is also joining late for the session. But we have also Sri Big Mohitra, Director, Shinon HB Medical Session, also joined for the session, and Sri Vinod Via, Group Head, Marketing, Kim's Girls. So over to Sri Sanjeev Kurup, President, Ayurveda Promotion Society, to take over the sessions. Over to Sanjeev.
Good evening all. Thanks to Kerala FICCI, Dr. Sahadullah, Deepak, Savio and the team. Ayurveda Task Force is a newborn baby of FICCI, born during the COVID time, to see that, Ayurveda tourism, which is having a lot of advantages to come after the post-COVID scenario. So we are having the medical value tourism in India, as you are all aware. It is one of the destinations in Asia. Am I audible, or because it's heavy rain outside here in Cochin? Savia, am I audible?
You're audible.
Yeah, you are audible.
Yeah, because it is raining outside, that's why I just want to recheck. So as you know that, the medical value tourism, which has fetched more than 500,000 foreign patients last year. And basically, so few people are aware that, the medical value tourism comprises of the modern system, that is the medical treatment in the modern system, and in the alternate system, it comes with the wellness and Ayurveda treatments, and also now yoga. Yoga is also slowly coming in. So we do have eminent personalities in the medical value tourism areas like Dr. Harish and other prominent speakers, so that they can share their views on an important area like medical value tourism. May I now invite Dr. Harish Pillai? I don't know, there is no need for introducing him much. Anyway, as a moderator, I will have to do that. He is chairing the FICCI Medical Value Travel Committee and also member of FICCI Health Services Committee. He is the CEO of Aster India, Aster DM Healthcare Limited, and he was heading the Aster in Cochin, and we were participated together in the sessions. Welcome, Dr. Harish.
Thank you, Sajeev. Firstly, I must say that I thought that your background, you're really sitting on the beach, is it? Because that's the sound which I'm hearing. Really, I miss Kerala so much. And I think all the folks logging in would really.
This is our marketing strategy. When we sell wellness, we sell, when we sell a hill station, we will be in the background of the hill station. Mr. Najib and myself, we are working together with the Confederation of Kerala Tourism Industry. So we plan in such a way that whenever we speak from Kerala, we like to show something which is unique to Kerala. I have in my Cochin office.
Thank you. So thank you for that. I'll just make a few opening remarks. One is that our state, we need to really remove ideology from the sector, because folks in tourism have had a multi-decade benefit. Even this entire, the theme of God's own country, when we look at Amitabh Kant and other leaders looking at 870s to create something out of nothing. And that's purely the story of Kerala, where you leveraged on Mother Nature and made it a global hotspot for tourism is concerned. The situation in health sector is vastly different in the sense that we are basically sitting on a foundation of massive achievements, both from a public health point of view and also from a private provider point of view. From a public health point of view, the state of Kerala is often spoken as a model state for the rest of states within India and also amongst OECD countries because of the consistent investment in social sectors, education and health sector. That's why we have a public health system, which is the cynosure of many eyes. The very strange paradox which the state represents is that in spite of this significant investments in public infrastructure, including human resources, the fact of the matter, 70% of the provision in the state of Kerala is still in the hands of the private sector. So that's a paradox which probably begets another session in itself. What we need to look at is that currently our country is moving towards this concept of the United States of India, where each state government is competing with each other for the same market segment. Or because unlike tourism, we have certain logistic challenges as well as advantages. Now, for example, why I say that is that all the embassies in the country are located in Delhi. And most of the flight connectivity in terms of medical value travel destinations, direct point-to-point connectivity is also towards Delhi. Those kind of advantages are naturally missing when you talk about a state, for that matter, any state. Having said that, on the benefit side, Kerala is today the only state with 4 international airports, and I believe there is one more international airport somewhere in the pipeline. So at least that 4 international airport serves as a fantastic gateway to really leverage on the spread of infrastructure across the state. In many other parts of India, when we do a comparison, it's basically one large state and one large metro within the state. Whether it's NCR, you talk about Delhi; Maharashtra, you talk about Mumbai; Telangana, you talk about Hyderabad; Karnataka, you talk about Bangalore. In the state of Kerala, that's not the case. You have equal distribution between Trivandrum, Cochin, Calicut. Now Kannur is coming, fast emerging as a good destination. So that kind of equitable distribution of in terms of gateway accessibility, I think that is really good. The number 2 aspect is, historically, the state has been very fortunate when we look at even from a WHO point of view, the presence of clinical manpower per 1,000 per head population, whether it is doctors, nurses, paramedical staff. In fact, our state is the largest producers of nurses and paramedical staff in the country. And so we are already well positioned in terms of our spread of human resources. So that's the second biggest advantage. The third advantage, which I would say, is that when we look at case studies around the world, any target destination which has got a solid track record of general tourism, that is often not in the case of all countries, but some of those exceptions in our neighborhood. Well, for example, Singapore, whether it's Malaysia, whether it's Korea, they all have a good infrastructure for general tourism, and they have a brand as a good destination. And therefore, the crossover from general tourism to medical value travel is much more easier. So that advantage also Kerala has. The fourth unique advantage, which you have mentioned, Sajeev, in your opening remarks, is alternative medicine. Kerala is very well known for Ayurveda. Therefore, we can actually package this market as a center for integrated medicine. It's a holistic medicine capability, not only looking at curative aspect, but also giving a lot of emphasis for rejuvenation aspects and prevention. So that is a completely new market segment, which both traditional and modern medicine can partner together. The sixth important aspect, I would say, for any market is in terms of the support systems, whether it's the tour operators, whether it's the hotel and hospitality services, and the cost effectiveness of the entire package, which Kerala offers in abundance. What is missing, if you ask me, is this is where the big point of debate is, that we need to have a coherent published policy. If I look at different states in India, states, which was, I would say, a bit late in the queue in terms of recognizing the MVT potential, was the state of Karnataka, which actually put up in the public domain a coherent policy for promoting the state as a destination for medical value travel. This is still now missing in the state of Kerala. Therefore, one of the appeals which we have from the sector is that it should have bipartisan support irrespective of who remains in power, whether it's the left front or the UDF, does not matter. We need a bipartisan support for the growth of the sector. The simple reason, the rationale why we all say is that health sector is the largest employer within the state. If you remove tourism, we are the largest employees in the state in terms of, and also our contribution as a percentage to service sector aspect of GDP is very significant. Therefore, if you succeed as a destination to be, let's be very modest, if you can be in the next 5 years in the top 5 rankings within India at least, that will create substantially more jobs in the sector. It'll add like a local spurt to the local economies, and most important is we can cross subsidize. See, the fact of the matter is healthcare, especially modern healthcare and hospitals, are capital intensive. It requires a lot of funding to put up to get the land, the infrastructure, the medical equipments in place. And at the same time, we all know in the state of Kerala, there is a certain price point in terms of affordability. Beyond that price point, nobody was going to access any provider for that matter in Kerala. To sustain your business for a long period of time, you need to have a big chunk of medical value travel to cross-subsidize your own population and give you some sort of healthy margins. Otherwise, my big worry is that because of the huge cost structure which is prevalent in the state in terms of human resources cost and other challenges, it might go to the same route as what we see of private medical colleges, which most of them are struggling. So these are my opening remarks. Thank you, Saji.
Thank you, Harish. You are very relevant and your points are well set to the target. I think, we will have a more discussion on the particular subject, the orientation or the integration of the model as well as the alternate system, because Dr. Geeta Krishnan is here, a prominent Ayurveda person. And Dr. Geeta Krishnan is actually heading the Department of Integrative Medicine and Holistic Therapies, Medanta Hospital, New Delhi. He is a veteran in the field, a person who has traveled a lot outside and knows the trend of the newly, the medical value travel. Dr. Geeta Krishnan, please.
Hi, Sajeev. Thank you for that introduction. In fact, there is a small correction. I don't work with Medanta anymore. I am working with that Well Health organization since past 3 years. I was with Medanta in the beginning for about 10 years. I built that unit and program there in Medanta. So
sorry for that. I read about your profile which is given and for
no, that's okay. It's quite old.
Thank you very much. Anyway, sorry for the correction.
That's okay. But I was just thinking about what Harish was saying, and it was extremely important that we look at a 5-year horizon about how we are going to and what we are going to achieve, and identify a pathway for something like this. The idea of God's own country, which resonates even now after 30 years. So how do we do that for medical value travel is something very important. It's a philosophical question. It is not something which is very technical. It is more of a broader vision of where we want to take our state to as far as medical value travel is concerned, and getting people from across the globe is concerned. Of course, getting people from across the globe has only two or three reasons. One is, like people might come because it is technically highly advanced. Second is, it could be because we have a financial advantage of people coming over here. The third one could be something which is not available anywhere else is available here. So we probably have all these three put together. But my immediate concern for the medical value travel here in the context of COVID-19 would be that, I think that one of the major things which medical care requires is proximity to people, and that is something which is being really hindered by this COVID-19 pandemic. And we really need to have a what's it called, a net for us to fall back to during this period, and that's what we should build about. And that's what probably we should think about, even in terms of like the systems like Ayurveda, taking care of wellness area, or even in areas where it is beyond wellness, if it is going to be curative treatment, how as Harish had said, how integrative medicine can play a major role, how a new kind of a system could be showcased to the world, where holistically different systems come together and treat a person or a patient for definite outcome, is something which we need to think about very seriously. I think I really don't have any answer, regarding this COVID problem, because we do not know when this particular COVID-19 project of Earth is going to get over. We have no idea. We think that it might take about at least another 6 months before we have something of any kind of a normalcy across the globe, any kind of travel between Europe or major countries, which actually can bring in considerable amount of financial advantages to our country regarding like complementary systems of medicine, or or Ayurvedic system of medicine, or other or wellness care, as we call it in India, and or in Kerala, or what the other countries, like major feeder countries like African countries or Middle East countries would be to the real medical value tourism which is happening right now in India or in Kerala, where people will be coming for high-end kind of care, in highly technically intensive kind of care to Kerala. We need to find a solution for this. That's the only thing which I only have a question to all of you, because I cannot think about something. I'm sitting in Geneva here. Things are getting closed down. All the governments across Europe are using the way of closing down, but at the same time keeping the information from outside world, saying that things are probably safe here, because all of them want to roll back into business at the earliest point of time. So I do not know, to be frank, about a proper answer for this. But one of the things which I could say is that probably an integrative model for post-COVID, like syndrome management is something which we can really think about, because I think in the current rate, Kerala would have a very high positivity rate, or rather people who had already overcome COVID would be quite high within the state. If we can identify those group of people, and we can offer a post-COVID management program which is integrated with high-end care and as well as with wellness, and probably rehabilitations in different dimensions, we have something to offer in the next 1 year, 1.5 years. Beyond that is something which probably, as we said, we need to separately plan for. But I think what we immediately need to look at is the next 1.5 years. Thank you so much for this opportunity.
Dr. Geeta, because since I am associated with Ayurveda tourism for more than 25 years, mostly dealing with international clients from Europe. Now the market for the last 2 years, 3 years, it is totally changing, and we are now getting people from the CIS countries, like the modern hospitals are getting people from Middle East, and also Maldives and other Asian countries. Our market is entirely changed scenario for the last 3 years, especially Ukraine, Lithuania, Latvia, where the people are not aware of Ayurveda or Green system, now started coming in. And to be frank with you, up to March, when we are forced to close down during the lockdown, we are almost 80% of the branded Ayurveda resorts and hospitals in Kerala were running full house. And people stopped in between, and when we asked them to get the reimbursement back, they said no need to get the money back, we will utilize next time. So even when we started in October 15th, Kerala government has opened up the borders basically for the domestic travelers to come in. The Ayurveda Promotion Society, with the help of the Indian Medical Associations, the standards, we have set up the protocols which has been given through the tourism department. And what we have done is that a person or a patient coming from other states of India will have to come with the COVID negative certificates prior to 48 hours of his or her travel. And if it is negative, once he reaches, 7 days of quarantine is not required. On the 7th day, again we'll have to do a RT-PCR test, and again we'll have to get it negative so that he can continue for any number of days. slowly the medical visas are also started issued by the Indian offices. And yesterday I got 3 patients from US, people of Indian origin, but holding American passport. They got the medical because, with the certification, they were doing Ayurveda for a long time with us. So they got the visa, and we have done the same thing. Again, we have done one more thing. After reaching Kerala, we never allowed them to go straight to the hospitals to take the Ayurveda treatment. Again, after reaching Cochin airport, we have done another test. That means the person has undergone a test prior to his arrival. After reaching, they have done the test. And after 7 days also, they will have to do the test. And for the staff, what we have done, the protocol is that, we try to maintain, because of the physical contact, on Ayurveda treatments, we maintain the same number of therapists for the same patient, and even the treatment rooms are allocated for the same number of people, but we are only taking 50% or 30% of the occupancy rate. So this is the way we are trying to evolve, and slowly people are started coming in. So with very, what you call the Ayurveda sector also, though we don't have an emergency setup, we are tied up with the nearby hospitals, and all the tests and every emergency care is being taken by the nearby medical hospitals, and there is a synergy between them happening already. In such a way, if we go, I think, slowly we can come to normalcy, because, we love to live with COVID. That's a thing. Otherwise, in Kerala, majority of the small players, they're hardly hit with 8 months of shutdown, and 90% of the employees are given the employment and the salary, even though there is no income. So that's the scenario now we are having here in Kerala. But we are very positive that, it is coming, and the demand is so high. I personally get inquiries minimum 10 to 15 that, we are ready to come for a rejuvenation program or a detoxification program. So that, they want, they doesn't want to undergo a quarantine after coming to India, isolated in a hotel with 7 days or 14 days. That's the only thing which we are looking for. And government of Kerala has agreed for that. Now we are expecting the international flights to open up. I don't think we never had a slight case increase because of this. Because, we are monitoring very clearly every day, and we are having our cross-section of hospitals, interactions happening. Anyway, it's a positive note. So it's only a counter remark which Dr. Geeta, since you are sitting in Geneva and you are an Ayurveda person, you can understand, the need for people's importance on Ayurveda, because, Ayurveda doesn't have any direct treatment for COVID, but immunity boosting with the Ayurveda lifestyle, Ayurveda food, and Ayurveda treatments can really help. That image is being spread all over the world, and we are expecting more planes to come in. So now I move on to Abhik Motia. Am I pronouncing your name rightly? Abhishek Motia?
It is Abhik Moitra. Abhik Moitra.
Yeah, Abhik. Sorry, Abhik. You can start, it's what we call introducing yourself, and we can proceed on that, please.
Thank you so much, Sajivji. It's a pleasure being into such an eminent neighborhood of speakers. It is always a pleasure to hear Harish Pillaiji, Dr. Harish Pillaiji. He's a hero figure amongst the MVT companies and MVT people. Sajivji, you rightly said that the medical travel has begun again, but there is just one remark I would like to add to what you said. If somebody comes with a COVID negative test, report with him, then the quarantine part is not required. So they need to come with a COVID negative test, which is done in last 96 hours. And even before they start from there, they need to upload it in the government portal. And the immigration authorities here, if they find the same certificate in their portal, or they are carrying it physically, then the quarantine part is missed. They will have to report back directly to the hospital, and they will have to do the test again. If everything is okay, the treatment starts. Yes, you rightly said that in last 1 month or so, some trickle has started to happen. We are at 10% of what we were at our good months, but at least it has begun, and hopefully it will continue to increase as the days go by. Among so many eminent speakers who have spoken about Kerala, which has the right kind of opportunity to encash upon, and the kind of policy changes that are required to ensure that medical travel to Kerala increases. it is time that we remain, we foresee what kind of opportunities we have in medical travel. So instead of focusing only on what opportunities are there for Kerala, I will be speaking on the bigger topic, which is the post-COVID opportunities in medical tourism, because rest of the thing has been covered by Harish Pillaiji already. It was also a pleasure to hear Dr. Geeta, who is talking from Geneva. So there is a huge kind of an opportunity that COVID has presented in terms of medical travel to happen. Specifically, when we talk of India as a destination, allow me to bring forward the pre-COVID scenario, which is India was approximately a $5 billion destination, $5 billion destination, out of which the healthcare spends were about 3.6 billion. The remaining money was spending on food, accommodation, so on and so forth. Patients were coming from 126 countries. Some of the countries were contributing very majorly, and some of the countries were still giving a few medical visas, but they were still there. So 126 countries. Patients were coming from almost all kind of treatment, including the Ayurveda, for which Kerala is a champion. With our traditional medical sciences such as Ayurveda, we still have a lot of contributions still to make. So I would still like to believe we are taking steps towards making India a champion, but we are still not there. Setting the context right, even if India is a $5 billion destination, the total world is about $45 billion market. So we have approximately about 10% market share. The remaining $40 billion goes to the markets like Thailand, Singapore, Malaysia, China, Turkey, Israel, Jordan, Costa Rica, Mexico, Brazil, etc. The wellness market in Thailand and the traditional medicine market of China and the cosmetic markets of Costa Rica are huge, and India does not get much out of this. More importantly, the medical travel markets are expanding due to the growing economies of developing countries and underdeveloped countries, adding almost like 10% of an annual growth year on year. And if we combine all these things, it presents to us as an opportunity that even if we are able to take just a 10% of extra market share from the remaining 40 billion, which is 4.5 billion, we still go up to $9 billion market in next 2 to 3 years. This 10% growth, which is happening annually, even if we are able to take a 50% market of the growing market only, it still adds another 4.5 billion in next 2 years. If we are able to create new businesses, that is to create the wellness tourism for mental health, which is in huge demand these days, immunity boosters, congenital neuro disorders through Ayurveda specifically, or for pediatric health, we can add another $4 billion into this thing. So without doubt, the opportunity is huge, anywhere from $9 billion to $18 billion markets in next 3 to 4 years of time. And during the COVID, there has been a big impact on other countries. If we talk of the entire world, immunity has become the buzzword, and Ayurveda has a special recommendation for immunity. If you talk of Europe, where NHS is prevalent, the waiting time has gone up significantly because all the hospitals are already full with the COVID patients. If you look into Africa, the gaps into healthcare is a new topic of discussion. Just to give you a remark, that Kenya had only 155 ICU beds all put together. Middle East, the need for healthcare workers have gone up significantly. And India is the biggest exporter of healthcare workers to Middle East today. In the Americas, the trust on healthcare have gone down drastically. So the Americans are not trusting their healthcare system anymore, or at least that is the feeling. If we talk of overall, the need for congenital neuro treatments, which is the development delayed disorders, the cerebral palsies, the autism, and so on and so forth. If we talk of mental health, the wellness tourism, the dental health, the endocrinological treatments such as diabetes or hypertension, or if we talk of cosmetic, these demand have gone up tremendously. So this is the opportunity that we have in our hand. Meanwhile, if we talk of India's position during the COVID, India has supplied medicines to 55 countries during the COVID and has sent its own medical teams to 5 different countries, including Qatar, to treat their patients. The Oxford AstraZeneca vaccine is among the front runners in the world today. India's indigenous Covaxin, which is made by Bharat Biotech and ICMR jointly, or if we talk of Zycovid-D, which is made by or getting developed by Zydus Cadila, are in the final phase of clinical trials. And all the COVID deaths, if we talk of, we still remain one of the better managed countries, and the world is taking a note of this thing. If we talk of this all together, despite our COVID numbers being high, India's healthcare system is still getting talked all over the world. And just to put the context right, the WHO head has commented on India's well-managed COVID scenario just a few days ago. And with all these things, we have geographical opportunities available today. Sajivji, sorry if I'm taking some extra few minutes, but I'm trying to put the context in right. If we talk of US alone, India and Indians are possibly most talked about during the last few months by both the current president and the president-elect. The yoga and Ayurveda are catching up fast, and because of the immunity talks about Americans, and people are, if you look into the enrollment into Ayurveda institutes, it is all-time high right now in America. India has supplied SCQ to US. You know, the US president almost threatened us if we don't supply it. The huge job losses in America, which is also a very big thing to talk about, have resulted into lesser number of people paying insurance premium and the need for low-cost health. And this need is going up right now. Harishji did mention about the inadequate insurance system in India, or the previous panelists did speak about it. And yes, that is a very prevalent problem in US today. So the opportunities, if we talk about US only, the uninsured market is looking up to us to help them out. The insured market through insurances, because every insurance is trying to save some money right now, and this is the right time to approach those insurance players. The wish-based market, and what I call wish-based market is this is not a need. So the wish-based market of cosmetic, the bariatric surgeries, the mental health and wellness and Ayurveda, they present a very big opportunity if we talk of US market. Talking about Europe, as I told you, the waiting time in NHS has gone up significantly. And from the possible government intervention from India, we can get these patients to travel to India. The wellness Ayurveda was already in demand in European patients, and it is time we should promote therapeutic Ayurveda as well. And nobody talks about therapeutic Ayurveda, but it has got tremendous, if we talk of psoriasis for that matter, or no intervention, spine treatment for that matter, Ayurveda has a huge role to play in there. And Europeans used to travel to Turkey for their medical travel, but the relationship between Turkey and European nations have taken a dip recently, and that plays a very important role in putting India on their map. So there is a huge opportunity for NHS outsourcing. The mental health market, especially from Northern Europe, those Slovak countries, is huge. Immunity and wellness market present a very deep opportunity, and the Turkish markets for European patients may shift to India if we focus there. Talking about Africa and Central Asia, people from Africa and Central Asia have always favored India. But it is time that we penetrate even deeper to take some markets away from South Africa, such as Namibia, Gambia, Angola, etc., which are not coming to India as of now and going to South Africa. And there are some opportunities that we can take some markets away from Turkey, such as Ukraine, Kazakhstan, Armenia, Azerbaijan, which are going to Turkey these days, because the relationship has not been great these days. Thanks to the Russia-India friendship in early years, Ayurveda is popular in the Central Asian countries. It is time we tell them about our superlative institutes that we have and the therapeutic side of Ayurveda. And I'm sure patients will start traveling to us. Now, the congenital neuro disorders are large disease groups in entire Central Asia. If we talk of cerebral palsy, autism, development delayed, etc., etc., it is time that Ayurveda Institute, which have a potential treatment, if not 100% treatment, at least we can symptomatically treat them. We need to present them and market ourselves with these kind of products. And to Harishji and to remaining modern medicine hospitals, transplants presents a very big opportunity along with our oncology offerings. There is a Middle Eastern opportunity as well. There is an enhanced scope of soft export, which is manpower exports, we can still increase number of doctors, nurses, and paramedics because they are in high demand right now. With reduced dollar earnings from oil export, people from kingdoms like Saudi and UAE are more likely to travel to India. They were earlier going to Europe. Europe is in bad shape. US, the dollar prices have gone up and the oil prices have reduced. So the economies are now looking for something that can cost lower, and India presents a very important picture there. With Europe, with presence of South Indian diaspora in Middle East, there is likelihood of travel to South India, and thus Kerala will become a very hot spot for this kind of travel if we are able to target them properly. So there is a large opportunity, there is a large prevalent of insurance there. So number of insured cases have gone up since the time UAE, Saudi and Oman have made it mandatory for corporates to have insurances. So there is a large opportunity in the insurance sector there. There is a large opportunity in government-sponsored patients who were earlier going to US and Europe for their treatment. If we are able to approach the governments of Saudi, UAE, Oman, there is likely chances of these traveling to India because of our lower costs. There is a large post-treatment rehab market also, especially for the neuro rehab, paraplegia, and diseases like this. Lastly, if I come to the opportunities in Southeast Asia, with Malaysia and Thailand becoming the victim of COVID and politics, both put together, there is an opportunity for Indian healthcare in Southeast Asian markets. Countries like Indonesia, Vietnam, Myanmar, Mongolia, which have been traditional markets for Thai hospitals and Malaysian hospitals, are looking for treatment in India now. The transplants market, so liver transplant, kidney transplants, from these markets are already coming to India, but this is what is coming right now. So there is an opportunity to introduce oncology, cardiac care to these markets due to cost saving. Once also that the dollar prices have gone up and Thailand and Malaysian and Singapore markets have become slightly more expensive. All we need to do is introduce our quality-based services for non-transplant treatments to these markets. But these are opportunities. This cannot be managed well or encashed upon unless we have some kind of support coming in. And the support that is required to tap into these markets are, we need to strengthen our distribution chain. The medical travel companies need support and handholding. And Harishji would agree that close to 70% to 75% of international patients, which is almost 800,000 patients coming to India every year, 70 to 75% are brought in by medical travel companies. We need to put our efforts to organize them and strengthen them. Maybe it's time for hospitals to invest efforts, not the money, invest efforts into the MVT companies and grow them to become their extended arms. The government's involvement is much required to make an entry into NHS. Turkey has done it in past. It is time we do it as well. The direct flights from Southeast Asian countries like Indonesia, Myanmar can immediately boost traffic. This is one thing which is stopping them to come over. As a community, we need to plan long-term with strategic alliances and investment into market development program, not keeping in mind what we are going to get after 2 months, but keeping in mind what are we going to achieve in 2 years' time. So it has to be a strategic investment that needs to be done in making this opportunity happen to India. Opportunity for sure is there. Yes, it is there, but for sure we will need efforts to encash upon that opportunity. That will be it from my side, sir. Sanjeev ji.
Sajeev, with your permission, I need to go for another meeting. So just a few closing remarks from my side. I'm sorry, my friend Vinod is there. I'll be missing out his thoughts. But Abhik has given a huge overview of global trends, and there are some of these threads of opportunities which the state of Kerala needs to pick up. What I'm just expressing my worries that in the past 5 to 6 years, I find that the government of India at the center level has recognized medical value travel as a coherent and important earner of foreign exchange for the country. This is why in the champion sectors, Niti Aayog has actually spotlighted medical value travel as one area which the government of India needs to focus on. So the MVT task force, which I had the honor of chairing, And previous in 2 years back, I was a co-chair right from the beginning. We were looking at how to improve the ease of doing business and to reduce entry barriers. So whether it's cost of visa, this ridiculous issue of FRRO regulations where patients are asked to go and report to the nearest police station about providing quality standards for medical value travel facilitators with the help of NAPH for designating international airports as gateways for the country. And the most important aspect is to put money where the effort is being made. That is Advantage Healthcare India, which is hosted, which is funded by the government of India and hosted in a very big way in Delhi. And it covers more than 67 countries across a wide geography. And that sustained effort over many years. And this time we had a virtual event. It really shows that the government of India is pretty serious about it. One point which even in Delhi we used to debate was, we used to often tell that Delhi is not India. Clearly, I mean, India is a subcontinent. So we used to tell that it's not really fair to invest 8 to 9 crores and have this flagship event only in Delhi, which is not fair. You must give opportunities for states of India also to partner with that. And that feedback was actually taken quite seriously by the government of India. And they wrote to different states to ask them to join as partner state. So the first state which volunteered was the state of Karnataka, which in fact hosted Advantage Healthcare India in Bangalore a few years back. The worry which I was trying to articulate is, we don't find a similar effort in the state of Kerala, where the government of Kerala needs to recognize that what the government of India is doing is to improve ease of doing business. So at least from a policy point of view, as a state, what are those things which can make life much more easier for the providers in the state of Kerala? A few years back, in fact, it was exactly 2 years back, we were quite alarmed to see, alarmed in the sense that the competitive spirit of other states in India. So I can give you the example of state of Tamil Nadu, where the government, in fact, organized roadshows in West Asian countries, in GCC countries, which is supposed to be a natural market for Kerala. But the Kerala government to date has not really done a roadshow where showcasing the opportunity for this destination as medical value travel. So that is why I mentioned in my opening remarks, is very important for some sort of a think tank. Like we assume like Niti Aayog in Delhi, we have an equivalent think tank located in Trivandrum, which is responsible for policy formulation, especially economic and social policy development for the state of Kerala. And my strong advice is to look at 1 decade, 2030, but look at a near-term plan for next 5 years. Believe me that COVID, whether it's 2021 or 2022, there will be a huge rebound of pent-up demands. We must use this opportunity to solidify our gains, strengthen our existing strengths anyway, and also showcase what we have to the rest of the world. Like you mentioned, Sajeev, that there could be opportunities in unconventional markets which we have never thought of, for the reasons which Abik has already mentioned, whether it's to do with stressed out systems in their own home destinations, where they just can't afford to be in the waiting list, tapping out and reaching out to insurance companies which are price sensitive. There is an opportunity already. Kerala, the tourism sector has thrown up opportunities for charter flights, especially for key targeted. We can easily do that for medical value travel. So these are some real life points which I know that leaders like Dr. Sahadullah, I mean, he has been knocking at all doors possible to sensitize the government of Kerala that this sector is of strategic importance, mainly because of the job creation potential. So these are my closing remarks. Vinod, I'll catch up with you and hear your comments later. Dr. Sahadullah, pleasure to meet you virtually. And thank you so much, Vicky, Savio, Matthew, and others for having me. Thank you so much.
Thank you, Harish. And as you know that, just a closing remark before you leave. Unfortunately, the health department, Dr. Sahadullah may accept my the tourism department and the private sector investors go in tallying each other for the last 25 years, making the tourism marketing effort all over the world by participating in international exhibitions, international road shows. So it has become a synergy for the government of Kerala to recognize the private sector participation in the tourism life. Unfortunately, the health department, they still remain in a different molecule, in a sense that, they are not doing any sort of marketing or any sort of help to the hospitals. That is what we are generally seeing. Since we are happy with the government of tourism and the tourism department is helping us, we have not gone in detail, but Saradullah and team, definitely, I think, your parent company, all those people can work together. I think, 5 years or 6 years before, we all participated once in some exhibition overseas as a Kerala medical destination team, something like that. So I think, after this COVID, marketing strategies are there. We people who are in the advisory committee, we will put it across, and we will try to pressurize the government of Kerala. Generally, even I was talking yesterday in the FICCI meeting that there should be a synergy between the three departments, like the ICE department, the tourism department, the health department, and the external affairs ministry, because the visa formalities, the FRRO issues, all you mentioned, Harish, very relevant. So we expect some changes, even requesting the government to issue free medical visa. I don't know whether it is going to touch, but definitely post we can, if we work together, we can get all these things. We are working on that, and Ayurveda Task Force Committee formulated most of the people from Kerala, but we are having a cluster of people from other states also to give their inputs. And we are working happily, and hopefully we expect some positive take. Thank you once again, Harish. Before you leave, thank you very much for your time.
Rajiv, just one remark is that if you look at the template in the government of India, is that the entire mission is driven by Ministry of Commerce, mainly because there is a division underneath them called the SEPC, Service Export Promotion Council of India. So they have declared medical value travel as a services export aspect of India. That is why there is so much of support by government of India in policy formulation. We don't go to Ministry of Health and Family Welfare in Delhi for any sort of help because their priorities are different. In my opinion, it would be a similar mistake in Kerala to approach Ministry of Health and Family Welfare because they have genuine public health issues which they need to really look at. The focus department in Kerala should be equivalent of Ministry of Commerce, which is Ministry of Industries. And its unit in Kerala should be KSIDC, the Kerala State Industrial Development Corporation, which also funds services in a very big way because of experience in IT sector, education, and also modern healthcare. So if you get these two things together, even in terms of a white paper of which department to focus on, I think it should be fine. There has to be budgetary allocation in every annual budget. The sector need to really lobby with the finance minister of Kerala. We need to tell them what are the sector specific demands, and that should be sustained over a period of time so that people realize, at least the political hierarchy and a couple of our bureaucrats get sensitized to the efforts which is already done in the central government. We just have to replicate that in the state, and I think things will get moving. Thank you so much. Thank you.
Thank you, Harish. Thank you for your inputs.
Thank you.
Now, Mr. Vinod, introduce yourself and get in so that you know.
Sure. Good afternoon, everyone. I'm Vinod here. I currently work as the group head for marketing with King's Health, based out of Trivandrum. I was in the healthcare industry for close to last 30 years, both in the medical devices space as well as the hospital marketing space. So it has a bit of exposure in the medical value travel as well. See, one of the challenges being the last of the panelists is that most of the points that you have jotted down as your talking points is all gone. So probably I need to find out from my list if there is anything which is not taken. Probably there are few, and I would rather want to limit myself to the Kerala scenario because Abhik has given us the larger perspective of the Indian scenario from international markets, because Kerala in medical value travel is pretty different from what the larger picture of India is. See, few things that we could look at ideally would be, rather than looking at multiple specialities being focused, we should rather look at procedure-based promotions in these markets, where we could talk about transplants, oncology, neurosurgeries, and the likes, and the cosmetology as some of the basic specialties that we should be focusing. Today, the challenge with Kerala is that we are present, or we are marketing ourselves only in a very limited market, which is Middle East, SAARC, and to a very lesser extent the African markets. And even when we talk about SAARC, it is mostly confined to Maldives. So our business again goes back to the Middle East. There, Oman serves as the largest amount of patients, and then followed by UAE, Qatar, Saudi Arabia, and the like. So we still have a lot of opportunities in the Middle East markets, which we should be looking at. And probably we need to draw up a plan where we look at a short-term approach to certain markets, a medium-term approach to certain markets, and a long-term approach to certain markets, which at this point of time is not really there. And Kerala being one of the, I would say that one of the nascent states in India where concerned about the medical value travel, because there are a lot of other states and a lot of other hospitals have been in this industry for last 20, 30 years, who has already invested big time into a lot of other markets, which Kerala hasn't done. So that's one opportunity we have to look at, expanding our markets into probably Southeast Asia or the African markets, which has got the potential, which is currently traveling to India as well. Like earlier, most of the people said, the other opportunity we have is how do we tie up with Middle East governments? Ministry of Health is an opportunity that we all have, which is something that most of the hospitals have started working on. And also the insurance, like everybody was very, very sure that insurance is the way to go ahead for us, especially from the UAE markets and the newer markets, which is opening up for insurances because of the cost benefits. Even if they allow a bystander to come in, take their costs, travel cost, everything, they are still far cheaper than what the local markets offer. One of the other areas that we see is some of the specialties like orthopedic, spine, and all that is gaining popularity within the Middle East markets, because a lot of hospitals and hospitals and the groups have started, hiring orthopedic surgeons and spine surgeons in their fold. So the number of referrals that is coming out of, or the patients traveling out of these markets into Kerala or India is on the lower side, or it is reducing. So that's another challenge that we would face. So that is where we need to look at newer opportunities in terms of procedures, which these markets would take some time to catch up with. So in that aspect, transplant would stand out as the single largest opportunity for all of us. That's something that we need to clearly look at. And the other thing, we also need to look at is, the kind of patients we need to have and the kind of investments we need to make when it comes to the international businesses or the medical value travel. Currently, we are looking at whatever opportunities available in the markets. We are just trying to get a share of the pie and not trying to develop the market, unfortunately. That's something that we probably need to look at. And that is where, people like Moitra and the support teams, like the markets which, the people who are into the medical value travel by themselves, will come in very handy, because for us to do any activity in a CIS market would be very, very difficult, because we don't really have the contacts or the acumen to do that at this point of time. And that is where they would come in very handy for us, and they are willing to extend their support to us. Unfortunately, the situation is, all these people are more focused in the North Indian markets than in Kerala. So we haven't really seen a national player like ABIC actually doing much work in Kerala. So that's one more opportunity I would think that, we need to discuss with people like ABIC and the likes to see how we take their support in bringing in more patients from different parts of the world into Kerala. So I think there are opportunities for us, and post-COVID, yes, we haven't really started getting many patients from international businesses at this point of time. Yes, but then there are opportunities. See, one of the closer to home areas where we haven't still been able to get a breakthrough is Sri Lanka. Sri Lanka still, most of them travels to Tamil Nadu, Chennai, and to a lesser extent to Bangalore. But then Kerala is very near, and probably looking at the cost part of it, we are far more cheaper to them than traveling to Tamil Nadu. But somehow, we are not being able to get a real breakthrough there. That's one opportunity that we should be exploring closer home. And probably, I would reach out to Mike. We can check with him if there is an opportunity which is existing for us in that segment. Most of the other points that I really wanted to talk about is already being discussed in length, and I think this is what I would want to put across from my side.
Abhi, you want to sum up something, because I couldn't get time to sum up on your presentation because Harish ji was supposed to go. You have done a wonderful case study in the sense that you have done a lot of homework by seeing and evaluating the areas where we can concentrate. It's a good thing, and it is informative for all of us. And you have to look in two directions, because I am focusing. I am focusing mostly on the Ayurveda concept because I'm from that field. Almost 10 years before, we started promoting the therapeutic importance of Ayurveda, and we started promoting where Ayurveda can give result. Neurological and muscular areas are having very good effective treatments in Ayurveda, which we were focusing, especially the neurological complaints where the modern medicine cannot give much support. People are coming. We are getting a large chunk of people coming for multiple sclerosis, motor neuron disease, like that, which is connected. So there is a chance of exploring the possibilities, and as Sahibullah doctor knows, most of these Ayurveda properties in Kerala are small and handy. We don't have inventories more than 35 rooms. And the European fascination to beach, whether it is a wellness treatment or a therapeutic treatment, the European fascination to the beach is actually the hot cake for the beach properties. But people like us who are not in the beach, we are doing the traditional Ayurveda services for generations. We are also getting people because there are takers for the therapeutic treatment and repeated clients. Even from people from far off places, they used to come every year. And since our inventories are very limited, we can manage it better and in a safer way. And the synergy between the modern hospitals and the alternate system of hospitals is the need of the hour. Because, I used to supply minimum 5 or 15% of my clients to the nearby dental clinics where, these people are finding a chance to do the industry. Something like that, it's all win-win situation. So I think, this will make us more closer. This medical value tourism concept will make more closer the strength of Ayurveda and also the strength of the modern system, so that it's a equal and complementary thing, so that all can work together. For the tourism angle, we are getting support from the tourism department, government of India, because our strength is too much. So the modern medical hospitals and the laboratories and the dental institutes come to a forum, so that the oil should be made more public, so that the government will look into that. We made the government to sanction 455 crores to tourism industry for the entrepreneurs, 25 to 25 lakhs, whatever it is, and for employees, then for the houseboats, then even for the travel guides. So nothing has been given from the central government, no incentive or any note even made. So now we are focusing to get the industry status for tourism, because we were having the industry status earlier, and 96 or 2000, they have removed the industry status. If we get industry status, a lot of incentives, and also what Harish Pilla has said, we can come, and so we are even trying to get it through the industries department to get it notified as an industry. So all things are going on, and I think with the support of Dr. Sahibullah and people like people who are expertise in the field, we can work together and we can make it a sort of team, so that we can knock the doors of the government once again. Mohita, please, you can add on.
Thank you once again. Beyond the government, there are a lot that the private players can do by themselves. Or if we have to lobby to the government for a variety of other things, the first thing that we need to look at strategically looking into markets, things where Delhi's and the Mumbai's are struggling today. Vinodji, specifically for you, if you have Dr. Sahadullah to help you over there and the other people, a simple thing like the availability of donor organs, lungs, hearts, cadaver livers, cadaver kidneys. You know, the moment the Kerala government just allows them for the international patients to be there in the queue, and I'm not saying priority wise, but at least there be on the queue, because the other state governments have put Indians on the priority. So the moment you do this, you know, one lung transplant is $70,000. Immediately you get a value boost. So if a simple thing like an availability of donor organs is made done, you know, all the medical value travel companies of Delhi's and everything will start looking at Kerala. So you not only get the organ transplant patients, you also start getting the other patients. That's one thing. So we have to make a strategic move here. Secondly, when you were also talking about the enhancing or expanding insurance market in Middle East and everything, and you just mentioned that the medical value travel can come handy in Central Asian market. Allow me to suggest that medical value travel companies, which are the primary distribution chain, and that is how Delhi succeeded in getting 70% of medical travelers to come in, because they give, the hospitals in Delhi give the due importance to medical value travel companies as an extended distribution arm. If we take the same attitude, then that expansion will happen exponentially. So you have to involve the medical value travel not only in markets where you can't go, but also in market where you can go. So because these are the people who are serving these patients. Allow me to bring to the point that even the medical value travel companies based out of Kerala are sending their patients to Delhi. The question is why? Because probably people here or the hospitals here have some of that extra attitude in serving those medical value travel companies, and which probably Kerala has missed. You just mentioned that we have not been there, but let me tell you, we have been sending patients to Chennai, to Kerala, to Kochi, even to Rajagiri Hospital, which is your neighborhood hospital. We have sent patients to KIMS, we have sent patients to Aster Kochi, and we send them regularly. But there is a huge service gap. The way the patients are handled in Bangalore, which is near you, or the way the patients are handled by the hospitals in Delhi is far more advanced or evolved in a way the medical value travel companies or patients are handled in south of India. So there is this approach gap happening there. We need to, you know, bridge this gap. Just to bring at a point how medical value travel companies are not only handing in reaching out to market, but they are also mitigating your risk. They share the risk of marketing expenses. They share the risk of return on investment. And the insurance companies where you are approaching, if a medical travel company is giving you a guarantee of payment, which means whether or not the medical travel company receives its payment from the insurance, you are getting paid. So even the financial risks are mitigated. So there is a lot of value if we start, and that is the mistake most of those hospitals or states are doing, where the hospitals are trying to reach out directly, and they ignore the importance of medical value travel companies in the whole system. So that's one approach gap. If you do it, I have always been telling the distribution chain, and you are from distribution selling background, sir, yourself, you would understand it better. The moment you go to a distribution chain, your expansion into market is exponential. So you have to look at them with that kind of not as somebody who is trying to make money out of being a middleman. No, they are not. Let me tell you that medical value travel company, one base here, their research paper was getting published in Harvard Business Studies. People like us, which is Chinon HBG Medical Assistance Company, we are looking at mergers. We are looking at coming up with IPOs in next 2 years' time. So, and the advent of people who are coming in, they are much evolved into this business. We are no more, or there's still a significant those stout-based thing, but then there are handful of those companies which have evolved through the business. Look at us as somebody who is partnering you to reach out to markets, and we become your extended marketing arms. Talking about incentive, Sajivji, you just said incentive. Let me tell you, there is a
Sri Abhik, I'm sorry, here we'll have to wind up.
30 seconds. That's 30 seconds. There is a 7% incentive on dollar earning provided by Government of India through their Export Council. If you are earning through dollars, and if you give that statement of accounts to the Export Council, they give you 7% return. That's the incentive which is already there for the hospitals and Ayurveda institutes. You need to encash on that. Thank you, Sergio.
I think Sajeev, we can wind up now. You have to sum up anything. I think no more questions posted in the chat. 6 is late. Yeah. So before winding, I would like to add some comments, sir. Dr. Shahidullah, please give your inputs before winding up.
Thank you very much. All the three sessions were really three aspects of our revival plan from this COVID-19 pandemic and the disruption. It went very well. On the last one, the medical value travel, we certainly have a lot of alignment to make, and either we collaborate or perish is the most important thing. All the people, all the players are very much required, and so I think we should see whether we can meet after these sessions and all the virtual sessions. We should join together either by Zoom and talk about an action plan by which we can approach the authorities. The reason is that, in fact, in Kerala, what we find is there is no ownership for medical value travel. And last time I confronted, in fact, the health minister, and she said that, okay, I understand your problem, and the health department will take the ownership. And that's what she told me directly. And so therefore, I think we can get together. And there's a lot of areas. I think the aggregators are very important, and the government is very, very vital. And joining together between Ayurveda and modern medicine is absolutely important. There is no doubt about it. So we are also looking at such opportunities. So I think the quality and the audit, the accreditation is very important. And so I think we get together and see an action plan, and too many things we work together, we may fail. I think select the important points and work together. And I think we have to improve this area. And as Harish Palla said, this is the only area where we get a little margin, so the losses made somewhere else can be met, or that gap can be closed by doing this. So with that comment, thank you very much for all the moderators and all the speakers, and it was an enjoyable afternoon, and I learned a lot. And Savio, if I could request you, with the help of the moderators, some of the salient points which have been said can be written and circulated to all the people, at least the speakers panel, because certainly we can use them. There are very valid points that have been mentioned, and we will try to do that, okay? And thank you very much. Yeah. Thank you very much. Let us wind up. And, once again, Sajeev and all the team, wonderful deliberation. Thank you. Thank you.
Thank you, Dr. Shahidullah. As rightly pointed out, we will be coming out with the action plan also. We will also circulate the details to the moderators also and get their views also, and we will be submitting the same to the concerned authority. Once again, thank you all our eminent panelist speakers and moderators for handling this session, especially the last moderator of the session, Sri Sajeev Group, and all the panelist speakers for being with this this session also. Thank you each and everyone, and also all those who have joined at the FICCI platform, the Zoom link for this session. Thank you everybody. We are waiting.
Thank you everyone. Good day.
Thank you. Thank you everyone. Thank you.